long academic session.
Yes, indeed.
Today we have two very important things. One is the radiological class and another will be instruments. So first, today's moderator of the first session is Dr. Bastav Ghosh, who is the consultant in MRI Dhakuria, with all his friends from MRI. I believe Bastav, all of them are from MRI. Cannot hear you. Please unmute yourself.
Dr. Hirok Raju has already joined there. He's a head of the department of the radiology department in AMRI.
Okay.
I can see Dr. Hirok here. And Dr. Anirban Mukherjee will be joining after some time because he's the consultant of radionuclide medicine. He will be joining after some time because his session is from 11, so he'll be joining around 11. I mean 10:45, something like that.
Okay. So from first half will be of Dr. Hirok Rai Choudhury, and moderator is Dr. Bastav Ghosh, and it's 10 o'clock. I think we should start the session in time so that we can finish this long, different sphere of the practical examination, both radiology, nuclear medicine, and instruments. So with this, I hand over to Dr. Bastav Ghosh to conduct today's session. And I thank all of the teachers, Dr. Hirok Rai Choudhury, Anirban, who will be joining later on, and later on Dev Mallo and others will also join. So I hope students will enjoy, and it will be very, very effective for them for the examination. With this, I hand it over to Dr. Bastav Ghosh. Bastav, please.
Thank you, sir. Thank you, Bengal Urology Society and East Zone East Zone Association of India for giving me this opportunity. And I pay my sincere respect to Kalyan Sarkar sir, Shivaji Basu sir, I can see. And so what we have discussed, that I'll be showing some images of radiology, ultrasonography, IVU, CT, MRI, and all these things. And then as we discussed with Dr. Desar, that Dr. Hirok Raju will give us some detail about the CT scan, MRI, which are like very much useful for our day-to-day urological practices. So the nitty-gritties and the images and the proceedings and how to read those things. So shall we start the meeting right away?
Yes, Bastav, we should start in time so that please.
Can you see my screen? Hello?
Yes, we can.
Yes, Bastav, we can see your screen.
Okay, so I'll start with the radiology thing. So who are the students over there?
Sir, this is Dipankar. I'm from Apollo Hospital, sir.
Okay, so start with you, Dipankar. Can you just
Yes.
describe the film which is seen in the screen?
Sir, this is an contrast image. This is an IVP, which is showing the region from the upper part of the kidney to up to the upper part of the symphysis pubis. Here on the right side, there is dilatation of the pelvic calyceal system up to the level of L4, L3, L4. And after that, there is the ureter is not visualized. On the left side, there is opacification of the pelvic calyceal system, and ureter can be finely traced up up to the middle part of the ureter, sir, middle part, and there is contrast in the urinary bladder as well.
Anything
The-
else can you see?
Sir, there appears to be a reverse J sign on the right side, sir.
Okay.
There is a medial deviation in the upper part of the ureter in the right side, which is
Okay.
indicative of a retrocaval ureter.
Okay. So nowadays we don't call it IVP, we preferably call it IVU, right?
Yes, sir.
So can you tell me the how should we take the image, like from where to where, for adequacy of the film?
Sir, first of all, we should pick a scout film,
Hmm.
and this should be from the upper part of the adrenals and up to 2 centimeter below the symphysis pubis. Here we will see the bony deformities, the soft tissue shadows, any calcifications or other radio opaque shadows, and also we can see the bony structures, sir. And after that, we will take the contrast images, sir.
And the bowel preparation also we see.
Yes, sir, bowel preparation as well.
Okay. So lower ribs to 2 centimeter, or the entire symphysis we take, and then what are the sequences we continue?
So the first one is the renal phase, nephrogenic phase, or the cortical phase, where after injection of the IV dye, 1 minute later, 1 to 3 minutes later, we'll take the first image. After that, we'll take another image after around 5 minutes. And after that, we will take around 15 minutes. And after that, around 30 to 45 minutes. The next one will be a cystogram. And finally, after completion, we will take a post-void film as well.
Okay. So the diagnosis for you is retrocaval ureter here.
Yes, sir, on the right side. Yes, sir.
Just briefly tell me what is the management, how will you proceed?
So retrocaval ureter should be managed when there is obstruction, there is symptoms, and there is deterioration of the renal function. And it is usually managed by open laparoscopic or robotic procedure, and where we do a ureterostomy or ureteropylostomy, sir.
Okay. So you mean to say not all the cases of retrocaval ureter needs operative management?
So almost all cases are symptomatic, or they present with functional deterioration over time. So almost all the cases will repair, sir.
Okay. So do you need further studies?
Sir, after a period of around, we will stent it. After removal of the stent at around 6 weeks or so,
No.
we will.
I mean, will you go for? Will you proceed with the management or surgical treatment with the IVU only?
Sir, we should go for a CT IVU, in which case we can see other structures as well, sir.
Like?
Sir, vascular anomalies can be there, and those things we can diagnose, sir.
So without CT scan, we cannot proceed with IVU.
CT scan, if available, is preferable, sir.
Okay. So if not available, then with IVU only we can proceed. Any further, any
yes.
other type of imaging?
So, and one, before proceeding, we can do RGP, sir, in on-table RGP.
No, you said that there is a deterioration of renal function or something. So
oh,
how
sir,
can
DTPA we should do, sir.
Exactly. So
yes,
we need
sir.
a DTPA scan to establish our treatment that there is obstruction, right?
Yes, sir.
Okay. Who's the next person? I can proceed with the next slide. Who's the next student? Is anybody there?
Hello.
Hello.
Sir, I'm there, sir. Dr. Anand Biani, sir.
Doctor?
Anand Biani, sir.
Okay. Oh, Dr. Anand, next slide for you. Can you elaborate it? Describe the picture.
So this is a view. So this is a this is an MCU film that is showing presence of hello, sir, can you hear me?
Yeah, tell me.
So there is a presence of grade, there is a presence of dilatation of the pelvic
No, first you
calcial
tell me
system with
what kind of picture is
along
this?
with the entire. So this is a image of a child with an MCU done, that is showing presence of sir, IVU done actually. Can't comment.
You are.
I mean, you said MCU, but can you see anything in the
No,
bladder?
sir. No, I can't see in the bladder, sir.
And how do you say this
So
is
this
a
is,
picture of a child?
sir, we can see the bones. Sir, the pelvis is also quite small, and there is a quite pubic diastasis. All these things are there, sir.
No, this is not pubic diastasis.
Mane, so
The
this is
epiphysis is not joined yet.
yes, the epiphyseal is not joined. Yes.
Fine. So this is an IV picture of.
This is an IVU picture of a child, which is one of the series, and that is showing presence of a left-sided gross dilatation of the pelvic calcial system with or grossly enlarged and tortuous ureter that is present, and it is visualized up to the level of almost the vesiculatic junction onto the left side only. So the right-sided, there is no opacification of the pelvic calcial system that can be seen, sir.
Okay. So what would this be possible? Like possible diagnosis?
So the possible diagnosis in the child that is having this, sir, it might be a case of obstructing megaureter, sir, or it might be a case of uh, the presence of a VUR.
VUR. Why would you
Sir,
say that?
actually, sir, sorry, not VUR. It is an obstructing megaureter, sir, and
Obstructive.
obstructive megaureter, sir, because
Okay.
it is not entering. It is not entering, any dye is not entering inside the bladders.
Okay. So what would be a possible line of management?
So in a child that is having obstructive megaureter, so we will be first of all seeing the child's condition. If it is not stable enough, then we have to first of all stabilize the child, and thereafter we have to save the kidney by doing a PCN, or it is a ureterostomy. And after that, once the child has become stabilized, and thereafter the the bladder capacity has also regained in size after with few years, we may basically go for a ureteric reimplantation for this child, sir.
Reimplantation only.
So that is going to be an excisional, it will actually be having two management, sir. One is going to be as a ureteric reimplantation, which is going to be along with associated excisional tapering or a infolding and tapering, sir. That can be done. If
So we call it tailoring.
tailoring, sir. Yes.
Yeah. And what about the right side?
So right side.
From this picture, we cannot see about. I mean, can I comment anything about the right side of the kidney?
No, sir. I can't comment, sir.
So then, what about? I mean, what will you do for that?
Sir, I would actually further investigate this child with the help of a functional study, and that is be a DMSA or a DTPA scan that can be done, sir.
Do we do DMS or DTPA in child, or we do something else for preferably?
Sir, in a child, so we go for a functional study preferably. We don't go for a CT scan in a child, sir.
Yes, of course. With which radionuclide material?
Sir, DMSA is preferable, sir.
Have you heard of MAC3?
Yes, sir. I've heard of MAC3, but that is not in India, sir. I think.
No, it is even available in Calcutta.
Okay.
So preferably MAC3. Otherwise, DMSA will tell you about the functional status of the both the
status
kidney.
of the kidney on the right and the left side both.
And do you need any further imaging? Like earlier,
Sir,
you have mentioned something.
Sir?
You have mentioned something. So patient will come with the ultrasonography primarily. So it will suggest that there will dilatation of the pelvic calcial system and the ureter. So
Yes,
would
sir.
you like to do some other tests?
So I would also go for an MCU for this patient, sir.
Yes. To rule out?
so any forms of reflux that can be there, or
Yes.
there is also chances of bladder outlet obstruction, like in posterior urethral valves, which are leading to the presence of bilateral refluxes, where in this situation it can be like a child is already having the other side that has become non-functional, and this is actually a side which is showing the reflux.
Okay. And it will also give you an idea about the bladder capacity, which you earlier mentioned, right?
Yes, sir.
Dr. Hirokura Chaudhary, do you want to add or do something? I mean, ask something, some question from this picture or regarding this? Hello?
Yeah. I believe I am audible.
Yeah, sure.
This image, whatever he has described is as radiologically, I feel that is good enough. But initial primary ultrasound would definitely give an information regarding the status of the opposite ureter as to diagnosing a bladder outlet obstruction. So that I think is an important information in the initial stage, which leads us to a bit of more information in the subsequent investigation.
Right.
Okay, sir. Okay.
Okay, so we move on to our next slide. Who will be answering the question? Dr. Ankit and Dr. Ashutosh. I can see both of them probably.
Yes, sir.
So is that Dr. Ankit?
Yes, sir.
Okay. Now this is for you.
So this is a X-ray IVP showing, sir, on the right side there is adequate expression of the contrast without any pelvic axial
So
system
first tell me
dilatation.
about the adequacy of the film.
That means
Yes, sir, the film is adequate, sir, but with slight poor wall preparation. Rest, sir, the exposure is good, sir.
Okay.
Yes, sir. Then, sir, on the left side there is contrast association, and also there is a slight dilatation of the ureter in the left lower part.
Okay. Anything else?
So it's likely suggestive of left side ureterocele, sir.
No, I mean, ureterocele needs further like criteria to be matched. I think something else is also there. I mean, only dilatation of the lower part is not suggestive of ureterocele. You need to see something else.
So there's a bulbous swelling at the lower end of the left ureter, sir.
Fine. And around the bulbous swelling? Can you see a halo around the bulbous swelling?
Yes, sir. We can see a halo. We can make out a halo around the bulbous swelling.
What does it suggest?
So lack of contrast over there. We suggest
Obviously
yes,
lack
sir.
of contrast, but why does this happen?
So intramural course of the ureter, because it's intramural, so bladder wall is occupying the circumferentially, so there won't be any contrast, so it will project as a halo.
Okay, so you think this is a ureterocele. Can anything else suggest if of this kind of picture? Is it possible in any other condition? What if there is a stone impinging at the VUJ? Can that produce a similar kind of picture?
Yes, sir, that can yes, sir, that can also produce, but sir, in that scenario, there will be, sir, the dilatation of the ureter will be, sir, more compared to ureterocele, sir, because ureterocele allow flow of urine, but impacted VUJ will won't allow any flow of urine, so there will be progressive dilatation. The picture can be
but not necessarily the entire ureter will be dilated always.
yes, sir.
But you need to see a scout film for that.
Yes, sir.
Right? Not only the single picture.
Yes, sir.
Okay. Dr. Hirok, would you want to ask something or add anything?
No, I think his description I feel is fine, but the only thing that sometimes is also visualized in ultrasound, which is really a primary modality, and it really adds to the amount of what Basta was telling regarding the edema around the VUJ. That is very well described in ultrasound if we look in a full bladder. So that adds to the information that we are getting here in the eye view.
Okay. So now for the coming to the next slide, Dr. Ashutosh. Dr. Ashutosh. Okay, if he's not there, then coming back to Deepankar. Dr. Deepankar.
Yes, sir.
Yeah,
Yes,
can you
sir.
describe?
So these are two IV use, sir. One taken at 5 minutes duration, the other one is at 7 minutes duration. However, the difference is one is taken at supine position, the other is in the upright position. In the supine position, we can see the level of the pelvic ileal system at around L2 level. However, in the second one, when the patient is in upright position, there is descent of the kidneys by around 2 to 3 vertebral levels. So this is renal ptosis, sir.
So, what is the clinching that you to comment that this is a renal ptosis and this is not normal descent while the obviously the kidney will shag down, all the abdominal organs will shag down to some extent while the patient is made upright,
Respiratory.
right?
Yes, sir.
And
So for
also the
diagnosis,
respiratory movement.
sir, for diagnosis of renal ptosis, there should be clinical features like the patient should have intermittent symptoms whenever there is an upright position. Then there
Okay.
can be features of obstruction like renal colic and on only when there is positional. And the second thing is that the descent of the kidneys are more than 2 vertebral levels, sir,
Right.
which is diagnostic criteria.
Okay. Fine then. So next, doctor was there, Anand, Dr. Anand. Dr. Anand? Dr. Anand is not there. Then Dr. Ankit?
Sir, I'm there, sir. I was actually saying I just found I was not muted.
Okay,
Sir,
okay. Just describe.
So this is an IVU. This is one of the films of the IVU series, which is taken at 30 minutes, where we can see that there is presence of left-sided. There is presence of a dye which is within the PCS system, which is going up to the ureter, and it can be traced down up till the level of the pelvic brim. There is the contrast that is also present within the bladder, and the left side kidney, right side kidney. I think, sir, it has already washed out the contrast, sir, because it's taken at 30 minutes.
What could be the other possibilities?
So the other possibilities, so that may be a non-opacification of the right side, which can be there, or it may be basic. So that is one thing, sir. And left side, I can't comment about the stricture because there is no the left side pelvic ileal system seems to be undilated, and also the ureters are also seeming to be normal only.
Okay, so basically right side non-opacification.
Yes, sir.
So you need to see the other films, right?
Yes, I have to see the other films.
Right.
But in
So
the initial films, whether it has taken the contrast or not, and now what?
Okay. Anything else which can produce a similar situation? Or if I say that patient had a right-sided abdominal pain, can that lead to some situation like this?
So the patient might be having a non-functional kidney because of a PUJ, but there will be a dye uptake at least in the PCS.
Can a functional kidney present like this? Can a right-sided functioning kidney? Is it possible? with the background of a pain on right side.
In acute pyelonephritis, sir, sometimes there
Pyelonephritis.
may be non-execution of the contrast because
Sir,
of
chronic pyelonephritis, there may be a scarred kidney which is not taking up the contrast, sir.
So that becomes a non-functional kidney. I'm talking about a functioning kidney.
Can't say,
In
sir.
case of acute colic, it might happen
Yes.
due to
With
stone.
acute colic, sometimes it can be like this. The kidney may not show opacification. Okay. So this is basically a normal eye view, not otherwise. Probably this patient was having a right side nephrectomy earlier done, but I wanted to know this one only. Point out that in a acute renal colic, eye view may not suggest, but then you need to see the scout film to
Other
see
films.
any stone, presence of any stone. Okay. Hello. So coming to our next slide, who will be answering? Dr. Deepankar.
Yes, sir.
So please describe the film.
So this is a contrast X-ray film, which is showing the pelvis up to the lower part of the symphysis pubis, which there is filling of, it's a cystogram, sir, and there is extravasation of the dye into the, I think, into the peritoneal cavity, because the outline of the bowel loops are visible.
Right.
Also, there is a filling defect, which is in the urinary bladder. Probably it is the Foley bulbs. And apart from that, I am not able to see any bony fractures.
Okay. So what could be the diagnosis?
So it is an intraperitoneal rupture of the bladder, sir.
Right. So what could be that filling defect in the urinary bladder, apart from
So
your Foley bulb?
So it can be a clot.
Yes. So what will be the management?
So intraperitoneal bladder rupture is managed by laparotomy and repair of the urinary bladder in the immediate situation, sir.
Okay. Before that, you need to check for other organ injuries, right?
Yes.
And
Yes.
if the patient is not stable, then you have to resuscitate, stabilize, and then go for bladder repair.
Surgical procedure. Yes, sir.
What could be the other type of bladder injuries?
So other bladder injuries can be extraperitoneal bladder injuries, sir, where the contrast extravasation is not inside the peritoneal cavity but in the perivesical area. There usually the extravasation is seen as flame-shaped areas, sir. Contrast extravasation.
Right.
There we have the option of managing it in a conservative manner by a prolonged period of catheterization. And if there is a significant urinoma, then we might have to drain it percutaneously, sir,
Okay.
with antibiotic coverage.
Is there any difference or mode of injury?
Yes, sir. If there is a penetrative injury, or if there is a high velocity injury, and if there is a bony spicule or injury in the bladder neck, and if the patient is having other injuries in the other viscera, or there is a open pelvic fracture, in those cases we have to go for immediate repair, sir.
Okay. And normally, how does the intraperitoneal rupture of the bladder happens?
So usually it happens when the patient, at the time of injury, the patient was having a full bladder. So because of if the patient is on a vehicle, 4-wheeler or so, the seat belt can compress upon it, or maybe the steering wheel or something like that, sir.
So either it could
Or
be a
direct
blunt trauma in the full bladder, blunt
it
trauma
is
happening in the
possible,
full
sir.
bladder, or
A
a
penetrative injury, sir.
Right.
Yes, sir.
Okay, fine. So who's next? Dr. Ashutosh was not there, I believe. He has not answered. So it can be Dr. Anand.
So this is a this is a micturating cystourethrogram film, which is showing that there is a good opacification of the bladder with the opening of the bladder neck, and thereafter the entire length the dye can be traced, but there is some amount of an extra vasation which can be seen at the level of the bulbomembranous junction that is there, sir, and I cannot make out any forms of a pelvic fracture which is if there is in this film, sir.
Okay.
Other than that, the anterior urethra is seeming to be normal, but we have to confirm it with the help of an RGU always.
Okay. So if I suggest that definitely this is MCU picture. If I suggest that it's a RGU picture which shows that the entire anterior urethra is normal, then what would be your diagnosis and management? Suppose this is an RGU picture which is showing that exacerbation of contrast in the bulbomembranous region and the bladder is being filled.
So that means, so there might be, sir, 2-3 possibilities are there, sir. First of all, there might be a iatrogenic injury which has taken place post a catheterization, which has led to this, or it might be because of falling an injury which has taken place, which has led to the extravasation of contrast, or there might be already that this patient has underwent already a surgery which has done, and thereafter still the patient is having some amount of anastomotic leak. So these are 2-3 possibilities which are found to be there for this patient, sir. So we
Okay,
have
so
to
how will you manage?
sir, if a patient, so we'll actually try upon, since we are seeing that the whole entire length we are able to enter into the bladder, and thereafter we will be basically going with the help of, so initially the patients are, if there is a trauma that has taken place, then in that situations, initial management will be an SPC, and then we'll have to wait for a bit, and thereafter we can go for a realignment, which is endoscopic realignment. But suppose if it is coming out to be just a iatrogenic injury that is post the catheterizations, we can go for a cystoscopy, and thereafter we can go for a if the stricture is a possible one and the guide wire is able to enter into the bladder, which we may pass on a catheter, and thereafter it can stay for 4 to 6 weeks, and thereafter we have to reassess.
So that is only for iatrogenic injuries.
Yes, sir.
Is that does that holds good for like an urethral injury actually? Traumatic urethral injury, not
no
actually?
traumatic urethral injury, sir. We'll be first of all going for a SPC, and then we have to give the
Always?
So not always, sir, but in patients who are males, we generally prefer to do immediate level and SPC, and thereafter we can go for a try with a realignment, endoscopic realignment later on, sir.
So my question is that all the patients of urethral injury, anterurethral injury, or bulbomembranous junction, that you should go for SPC, right?
Yes, sir.
So you should not be trying if you see the bladder with the RGU
single,
contrast
so
entering
there
the
are
bladder.
two school of thought, sir. One says that they can go for a single attempt of gentle catheterization if it is going to be passing, but the others are going to be saying about this, sir.
Okay, so can you just tell me the classification of urethral injury?
So the classification of anterior urethral injuries, sir, they are found to be as an ASST classification, which says the type 1 is going to be a contusion injury. The type 2 is going to be an injury which is stretched. The type 3 is the one that is going to be having a partial disruption, and the type it is going to be thereafter followed by the complete disruption, which is less than 2 centimeters, which is type 4, and type 5 is more than 2 centimeters disruption, sir. This is for the anterior urethral injuries.
Okay, so for the type 1, 2, 3,
Yes,
can we do a like well, definitely with the after the RGU, if we see the contrast is reaching the bladder,
so we can,
I think we can try a gentle attempt of catheter.
Yes, sir, we can try with attempt of catheter, sir.
Yeah, if it goes, then the job will be done, and we can keep the catheter for longer period of time.
Yes, sir.
Like this.
So this is an extravasation of contrast that is taken. So this is just the continuation of that film, sir.
No, this is another film.
So this
You
is
continue
also,
with this.
so this is basically a RGU film, sir. where we can see that there is the anterior urethra up to the level of the mid-bulbar region seems to be normal, but then there is going to be an extravasation of contrast, which is going to be post that. And I can't comment whether it has actually entered into the bladder or not. It is a complete extravasation that has taken place.
Yeah, there is no contrast in the urinary
Bladder.
bladder. So here we should go ahead with the.
Sir, in that situations, we have to ultimately go for a primary management, not the catheterization, but we have initially go with the surgery, and thereafter, so surgery is the treatment for this, sir.
What kind of surgery? So first we see the RGU and go ahead with the surgery.
No, sir. We have to see whether it is a traumatic ones or if it is going to be this one. So if it is less than 2 centimeters and more than 2 centimeters, we have to first of all see the defect, and then we have to decide whether we have to.
So here we can
go
see
for
the
a-
complete excavation of the contrast material in RGU. There is no dye is
So we
reaching
have to then
inside
go
the
for.
bladder.
So we have to go for the diversion first of all, SPC, and then we have to wait for the situation to heal, and then we have to go for an MCU, and ultimately by the help of it we'll be able to assess the exact length of the stricture, and then accordingly we can manage the patient, sir.
No, I believe it is a trauma, and probably this is associated with pelvic fracture. Although we cannot comment with this film only. I think we need to resuscitate the patient, assess the patient, and then see the condition of the bladder, whether there is any associated bladder injury. If the bladder is full, then only we can put an SPC. Otherwise, we have to go for an open one.
Open. Okay.
Right. And I think for any trauma patient, we need to comment about the general condition of the patient, whether patient is having any other injuries. Right. These are high velocity
I was not
injuries.
able- Okay, sir.
We need to do further investigation, not only with this RG one. Right.
Yes.
Okay. Now next will be Dr. Ankit.
So this,
Yes, sir.
Okay, Dr. Ankit.
This is ultrasonography film showing site of the kidney is not mentioned, but they're showing a well defined anechoic cystic lesion in the upper pole with
Can you mention whether it is upper pole or lower pole?
no, sir, but
How do you see or how do you understand? It is not possible.
yes, unless if we ourselves is performing the ultrasound, then we cannot know. So by the film, we cannot know, so whether it's upper pole or lower pole. So.
Right. So we can only see that this is a kidney with a hypoechoic region. I mean hypoechoic region at the pole of one of the poles of the
Yes,
kidney.
sir. Yes, sir.
And can you elaborate a little bit about the hypoechoic region?
So hypoechoic lesion is well defined with a with post acoustic enhancement, which suggests thorough transmission of the ultrasound waves via the system. Yes, sir.
True.
True
Not
transmission.
thorough.
Yes, sir. True.
Yeah. And there is no septi inside.
No septa, no calcification, sir.
Right. So, but I think that for any ultrasonography, we need to ask for the. We cannot comment about anything else but the picture which is shown here.
Yes, sir.
Whether the position, size, and other characteristics of the lesion.
Yes.
Okay. I mean, that holds good for any of the ultrasonography. It is usually IVU and CT scan will be given the whole series, but for ultrasonography, you need to ask for the printed report.
Yes.
So, what would be the diagnosis of this hypoechoic region?
So, looking at the present film gives most likely the idea of a simple cyst in the cortex.
Cortical cyst, simple cortical cyst.
Yes, sir.
Okay. So, how do you classify it?
So, basically, the cyst classification is on the CT, sir, which
Right.
is Bosniak classification, not on the ultrasonography, sir. Bosniak
Right.
classification. On CT, we have a Bosniak 1 simple cortical cyst, Bosniak 2, where we have simple cortical cyst with a bit of slight thickening of the wall with no calcification, no septa. 2F, there will be some bit of calcification in the wall we can see. In 3, there will be calcification of the septa as well as thickening of the wall. And in 4, we will have a solid component along with the all other features, sir.
You didn't mention about anything about enhancement.
Sir, in enhancement will be there in Bosniak 4.
No. Okay, we'll be dealing with that in detail in Dr. Roy Chaudhury's talk later in this series. Okay, what about this? Continuation of the kind of in the same topic.
So this one is showing us a septated lesion with the anechoic feature and thorough transmission, sir. And the septors are, sir, are showing echoic features. Yes, sir. And it's a huge, appearing to be huge cyst occupying one of the pole of the kidney, sir.
So anything further studies?
Sir, would like to have a CT, so contrast CT in this case.
And for that, we need to check the renal function first.
Yes, sir. Renal function.
Okay. So probably this could be the picture of the same thing, same
Yes.
ultrasonographic patient.
Yes.
And we'll be coming to the detail after some time.
Yes.
Next, who? Dipankar.
Yes, sir.
You comment on this picture?
Sir, this is an ultrasonography, sir, and it is transrectal ultrasonography, which is showing the prostate with few hypoechoic lesions, multiple hypoechoic lesions in the peripheral zone, sir.
Okay.
Yes, sir.
So what could be the hypoechoic regions or lesions in the prostate?
So hypoechoic lesions, most suspicious will be malignancy, sir, CA prostate. Other differentials will be an infarct.
Most commonly,
prostatitis or
hypoechoic lesions will be prostatic malignancy.
prostatitis or nodules, sir. BPH nodules can also present as hypoechoic lesions.
But prostate cancer is not the most common thing. Who
Sir,
presents as?
infarct, sir. Infarct, lymphoma, granulomatous prostatitis. All those things can also present as hypoechoic lesions.
But prostate
Sometimes
cancer
cysts,
is
sir.
but prostate cancer is not the most common hypoechoic lesion.
Yes, sir. Yes, sir.
The reverse is true, that majority of the prostatic cancer adenocarcinoma present as hypoechoic, but not the other way around.
Yes, sir.
Okay. The detail of the truss will be elaborated by Dr. Roy Chaudhury. I'll just go through a quick just diagnosis.
So, oh, okay. So this is one of the actual films of the CT scan, that is contrast that is in within the nephrogenic phase, which is showing presence of a hypodense collection that is around to the left side, almost occupying the surrounding the whole of the kidney, and has led to the upliftment of the has led to the shifting of the kidney towards the it has led to the upward shifting of the kidney as well. Most probably it is going to be a trauma that has led to this, sir, and it is a hematoma which is compressing on it.
Hematoma? How do you say that?
Sir, most probably, sir, it is not necessarily.
But you can see the contrast material in the aorta and both IVC, and the renal vein and arteries both are opacified. So had it been a case of hematoma, then
so they would also have shown the hypoechoic natures.
Yeah.
Yes. Yes.
So what could be this?
So this
Could
can
this
be,
be a
so
urinoma?
since this is a hypodense lesion, that can be basically a urinoma also, or it can be. Yes, sir.
So what do you ask for?
So I would actually, sir, ask for a delayed film, sir. That is going to be excretory film, sir. So this is a excretory film, which is showing that there is a. So there is also a contrast leak which can be seen onto the medial aspect, sir. which is suggesting that there may be a associated vascular injury as well, associated with the, oh no, sir, there is sir, actually there
The
are
same
further,
patient, excretory phase only.
sir, is there any other excretory film, sir? Because there is a complete cutoff which can be seen at the level of the PUJ. So there might be a UPJ disruption that has taken place and it has led to the urinoma which is collected, sir.
Where do you see the UPJ? I cannot comment anything about the UPJ from this film only.
So that's why I wanted, sir.
This
another,
is just extravasation,
yes.
contrast extravasation. You asked for excreted phase. I have shown you the excreted phase, which is showing the extravasation of contrast material from the pelvic ileal system.
Yes, sir.
Okay, so quickly tell me the types of renal injury.
Sir, so the classification says that so the type 1 is going to be having presence of only the contusion, and they will not be having any forms of a laceration that is present intraparenchymally. It is the
Okay.
type 2 which is going to be having presence of less than 1 centimeter laceration of the parenchyma, but there will be no extravasation. That will be no involvement of the collecting system. And
Okay.
thereafter, the type 3 is the area which is going to be having more than 1 centimeter of the laceration that has taken place. But there, and also there will be a collection that is taking place within the perinephric area, but that is not going beyond that. And it was also not entered into the collecting system. It is the type 4 which actually has entered into the collecting system, sir. And that has associated segmental renal vein and its branches that has shown injury. And thereafter, they may basically have the association of perinephric collections. Along with that, type 5 is a shattered kidney or a hilar injury which has taken place, which is associated with the major vascular injuries.
Okay, type 2 means that expanding hematoma.
Expanding hematoma.
Okay, fine. Quick comment on this.
Coronal reconstructive of artery phase of CCT. So this is a calcification. So this is going to be the kidney showing presence of a
Forget about the aorta.
yes.
Just comment on this. This is an arterial phase which is showing a contrast extravasation well
Extravasation,
circumscribed.
sir. But there may be basically a segmental branch that has got injured.
Could this be arteriovenous fistula or malformation?
Yes, sir. Yes,
Can
sir,
any
it may be an arterial
can this
fistula.
thing happen after the iatrogenic or any after the procedure, complication to any procedure?
So it can happen, sir. Yes.
How? Commonly it happens after
PCNL, sir.
yes. So how do we manage that?
So if the patient is hemodynamically stable, then we can go for angioembolization, sir.
First, we try to manage conservatively.
Yes, sir. We try to manage
If
conservatively.
continuous bleed, or is it or the bleed persists for longer time, we have to go for angioembolization. Right. So the same thing. Formal angiography, which is showing the arterial leak and arteriovenous malformation over here. Okay. We comment on this.
This is one of the axial cuts of the CT scan, which is showing presence of a right-sided enlarged kidney with presence of gas shadows, which is present inside the present inside the parenchyma, sir. That is there, along with the presence of perinephric fat stranding.
Okay. So diagnosis.
So this is seeming to be a case of emphysematous pyelonephritis, sir.
Classification.
So emphysematous pyelonephritis is actually divided by one into two ones. Just forgot the classification, sir. Actually,
Hohenstein classification: type 1, collection in gas in the collecting system; type 2, gas in the parenchyma; type 3, gas in the perirenal space; and type 3b, gas in the perirenal space; type 4, either solitary kidney or bilateral emphysematous pyelonephritis.
Okay. Quick management line.
So we have to stabilize the patient with fluids, antibiotics, and if the patient is not responding to those conservative measures, we may need emergency nephrectomy.
What do you mean by conservative management?
So we give IV fluids, manage the shock, then we correct the usually the elevated sugar, and we start broad spectrum antibiotics.
Anything else?
Other than that,
We
nowadays, sir,
can
we are
put a
stenting or
PCN
PCR
tube
might be required.
percutaneous
to relieve the obstruction.
stenting or a percutaneous nephrostomy, sir.
Percutaneous nephrostomy and or pectoral drainage of the
Degestant.
perinephric space. Anything else? Stenting?
We
Yes,
told
sir.
about DJ stenting as well as percutaneous nephrostomy.
Right. Okay. So anything you can see with the picture, just description.
This so this is an actual cut of a CT scan that is showing presence of a large large
Because this is an
mass.
arterial phase, right?
Yes, sir. This
Yes,
is
sir.
arterial phase, sir.
Okay. Then large.
So large heterogeneous mass which is arising from the upper pole of the left kidney, and that is seen to be continuous with the left renal
How do you
vein.
know
And
that this is arising from the upper part of the upper pole of the kidney, left kidney?
so actually we'll have to see the further cuts actually.
Then
Sir.
don't comment. You just whatever you see, you just tell.
So left side of the kidney, which is going to be seen continuous with the left renal vein, and thereafter it is might be involving the seeming to be involving the IVC as well, sir.
So possibility is that this is a left kidney
This is
tumor.
a case of a red. This seems to be a case of renal cell carcinoma, which is invaded into the IVC onto
Okay.
the left side.
Fine.
So this is basically a IVU film that is one of the series of the IVU film, which is showing that there is presence of a left-sided dilated pelvic calyceal system, which is seen with abrupt with no contrast that is going to be flowing further in the left side. And there is a right side which is going to be having only the opacification of the pelvic calyceal system, but it seems to be non-dilated. Also, we can see that the contrast has entered into the bladder.
Diagnosis.
So it seems to be the case of a left-sided PUJ obstruction, sir.
Okay. Fine then. So I'm sorry, Dr. Roy Chaudhary, I'm quite late. I mean, I'll be giving you the stage for your presentation, and please come and enlighten us about the proceedings of the surgeries, and the imaging modalities, and so Dr. Roy Chaudhary, please.
Yeah, thank you, Dr. Basta, for the opportunity, and I thank Urological Society of India East Branch for the opportunity of interacting with such wonderful students. So I believe in the next 40 minutes, I will be able to contribute at least something for them. So let's start with the commonest thing, that is if there is a lesion in the kidney. It can be a ball type or a bean type. That has been the classical teaching for radiology mostly. And the ball type has different differentials. The renal cell carcinoma, AML, oncocytoma, metastasis, lymphoma, all fall within the ball type lesion. The bean type, which is within the capsule, so it is transitional cell CA, renal cell CA, lymphoma, metastasis, infection, infarction. Now here, one thing is overlapping, that is renal cell CA, and that creates confusion in a lot of cases. Ultrasound, as I just go into a very brief thing about ultrasound, what has been found is up to 77% of RCCs below 3 centimeter are described as hyperechoic. So hyperechoic has quite a good number of differentials, and the commonest of them is an AML. And it has been found that up to 18% of tumors less than 20 millimeter and 21% of tumors between 20 and 25 millimeter are not detected using ultrasound. So here we are with ultrasound, but yes, it's not something really gloomy about it. we need to understand that Doppler has really enhanced the detection rate of tumors in less than or equal to 30 mm lesions. And what has more recent is a contrast enhanced ultrasound where gas bubbles are being traced dynamically for seeing the vascularity of tumors. And we can really comment on the washout that we have been doing in CTs for so long. And contrast enhanced ultrasound, because of its cost parameters, is not picked up really, but yes, we see a bright future for it and a much more easily accessible future for it. The CT renal tumor protocol, what I need to emphasize is, most importantly, any tumor that presents and is suspicious of a tumor in an ultrasound needs to be taken with a particular tumor protocol. And that tumor protocol gives us one-stop shop for all queries from the urology point of view, before surgery or what type of lesion it is. So in an indeterminate, say, let us deal with an indeterminate renal mass. So it is pre-contrast, that is the plain image, where what do we see? We see calcifications. We see whether there is cystic component. We see whether there is necrotic component. And nephrographic phase, 60 to 90 seconds post-contrast, is very important, where we characterize the enhancement. Though it has been said that indeterminate lesions have an option of going for the corticomedullary and excretory phase, but today's renal CT tumor protocol in most of the centers, as we follow in MRI, is a 4-phase protocol: pre-contrast, non-contrast, nephrographic, corticomedullary, and then the excretory phase. So corticomedullary is definitely before the nephrographic phase, as you can see. That is important for subtyping RCC in certain cases. We'll come into that. Now, pre-surgery or ablation, what is important? Arterial phase, very important, because the surgeon needs to know which artery, and if he is going for a partial nephrectomy, which arterial branch is really supplying the vessel, whether it can be clamped in the hilum or it has to be clamped beyond that. Nephrographic phase, corticomedullary, and excretory phase will add to the information regarding the excretory system as well. Now, this is the type of image that we sit with the surgeons for a sort of virtual surgery in our own radiology consoles to help the surgeon do a virtual surgery and then go to the OT, and really it helps them in orientation of the tumor while going through a laparoscopic or a minimally invasive mode. So this amount of information has been possible with the development of today's software and technology. But what is most important is these all can be done if a proper protocolized tumor scanning has been done in CT. What is more important in active surveillance, post-ablation, post-partial nephrectomy? It has to be a pre-contrast, a nephrographic, and an excretory. Collecting system injury, etc., can be ruled out in excretory. So those are the questions which come up when there is a dilatation of the collecting system post-surgery, and the excretory phase really adds information to the area of obstruction. Post-radical nephrectomy or post-systemic therapy, it has again to be at least 3 phases: unenhanced portal venous phase, 60 to 90 seconds, and the late arterial phase, 40 to 50 seconds, for liver and pancreatic metastasis. That cannot be missed, because that is important in the post-radical nephrectomy or post-systemic therapy follow-up. So here we have, in the last few slides, we have dealt with an indeterminate renal mass. First, what is the initial protocol? Then we go for what is the protocol pre-treatment, what is the protocol post-treatment.
तो जाने के बाद आओ फिर बता के आ जाना इधर पे
Hello.
Hello.
Can we really mute some of the mics? Yeah, thanks. Enhancement of more than 20 house-filled unit. Enhancement of more than 20 house-filled unit measured in corticomedullary phase. Now, what is an enhancement? That is very important, that everybody has to understand. That enhancement does not merely mean that it has to be hyperdense. No, a change of attenuation measured as more than 20 Hounsfield units in the corticomedullary phase. That is very important. And 10 to 20 is said to be indeterminate. That is the classical teaching. Optimal sensitivity and specificity for RCC is the cutoff value of 84 Hounsfield unit in corticomedullary phase and 44 in the nephrographic phase. And of course, these have quite a good number of debates on that. But what we need to understand is more than 20 Hounsfield unit. Now here we see a lesion. If any of the students are interested in picking up these lesions, please do. Anyone? Okay. So
there is a lesion in the mid pole of the left kidney, which upon giving contrast, it is enhancing. Okay. There are necrotic areas as well because it is heterogeneous in enhancement, sir.
Okay, so just adding to the information that you have really given us, one is it is partially exophytic. 1, 2, the hypodensity within can be 2 things. One is necrosis, one is fluid, might be due to necrosis, and third is most important is fat. So if we do the Hounsfield unit measurement of the central region, it might be fat as well. So it hasn't enhanced, but the rest of the part has enhanced. This is a clear arterial phase. You can see the aorta enhancing, and in the arterial phase, the tumor shows enhancement and good amount of enhancement in comparison with the cortex of the kidney. And in the delayed phase, you can see that it has washed out to a certain extent. So if it is a lesion with small amount of fat, an exophytic lesion, then what could be the differential diagnosis?
So the first differentials will be a case of angiomyolipoma, sir.
Yes. Can it be a RCC as well?
So it can be a RCC as well, yes, sir.
Yes.
Yes, sir.
So this was an angiomyolipoma. We'll come to the next, definitely. Thank you. Now, if there is a lesion, any lesion in the kidney, be it within the capsule, be it exophytic, if we are considering within the kidney, lesions can be of different types. Now, see, these are all lesions which have not really enhanced in the corticomedullary or the nephrographic phase to the extent the cortex has enhanced. Now, here is a lesion which is hypoenhancing. If we look into the collecting system in the excretory phase, we'll be able to understand. Here you can see the renal fat of the hilum, which is obscured here, and it has moved into the collecting system. It was a TCC. Here it is moving into the calyceal system. You can well see that. Another is an infiltrating hypovascular renal cell carcinoma. So all tumors which are hypotense or hypoenhancing are not really TCC. That is very important for us to understand. In these cases, we have other options of imaging that we will come to soon. Lymphoma is another great mimic where the kidney gets enlarged. It almost maintains its contrast enhancement pattern. But if we just look, what we have been gifted is that we have 2 kidneys to compare. Unless it is a bilateral disease, we can really see the asymmetry, and we can presume that the one showing the asymmetry is definitely diseased. Then we need to search for the differentials. Lymphoma can be diffusely infiltrative, can be focal if we are lucky enough. In that case, we consider the differentials of a TCC and lymphoma. Sometimes hypovascular metastasis, because kidney is a highly vascular organ, and the metastasis, the metastatic tissue might not be as vascular as the kidney. In that case, it can be a hypovascular lesion, which sometimes mimics a, say, TCC, if it is very near the pelvis of the kidney, and if it is in unluckiest of the cases infiltrating the collecting system. In that case, it is very difficult to determine. And the greatest mimic is the pyelonephritis, where an evolving abscess can really mimic a lymphoma. Clinical picture is the key to the diagnosis. Pyelonephritis can be diffuse, can be focal, or even a renal infarction. where it can mimic a TCC unless we have a clear idea of what the patient has presented with. So here we have a tumor where it is almost isodense to the kidney in the non-enhanced phase, and the corticomedullary space, you can see specks of enhancement of nodules being enhanced. And then it is a well encapsulated lesion, which is showing differentiation from the rest of the renal parenchyma in the nephrographic phase. So it was a renal cell carcinoma. Here, if anybody can pick up what is shown here. Okay, so we have a kidney that is relatively enlarged in comparison with the other side, and there is non-enhancing tissue extending through the renal vein. So this can be, what can be the differential diagnosis? It can be in a, even in a case of severe pyelonephritis, it can happen, renal vein thrombosis can happen. It can happen in case of diffuse infiltrating tumor in the kidney that the renal vein can be. So all differentials of renal vein thrombosis can be considered, but we have to see the images serially for the diagnosis. So additional information of venous structures, that is the renal vein, the IVC, the surrounding nodes, have to be looked into before coming to a diagnosis. And what is most important in this CD is that we do not need to presume the diagnosis. Both kidneys do have hypoenhancing lesions, and the liver is studded with lesions. So it is diffuse metastatic disease. A 67-year-old male. We were looking into the cysts Dr. Basta was showing. So cysts, we'll look into the classification and the updates of 2019 to the Bosniak classification that has been added recently. And we need to classify the cysts. What is important? Cyst wall, number 1. Number 2, septa. Number 3, nodules along the walls. Number 4, masses. And number 5 is enhancement. Enhancement of the cysts, cyst walls, nodules, and the septa. Now, what is the septa size? That is important. Classification, I was listening to the classification, absolutely. So that was the right classification initially proposed, and that we were following till recent times from Bosniak. And the septa, less than 2 mm, more than 3 mm. Now with the 2019 modification of the classification, it has undergone more than 3, more than 4. And the classification adds enhancement of the septa as well to those thickened septa. Here we can see some nodules in the walls. The mural nodules are enhancing. So it is definitely, all that looks cyst may not be cystic. That is the first thing in radiology that we practice, that all that looks cyst may not have the density of water. So that is very important to understand, and that really helps us in coming to a conclusive diagnosis. So next is enhancement. Here we can see some nodular enhancement along the walls. The cyst wall is irregular. So what would be the cyst classification like? Anyone? Any of the students can just pick up. It's just an
Bosniak
interactive
4, sir.
session. Yeah, please.
Bosniak 4, sir.
Bosniak 4. Okay, if you go to 4, what would you look into? 4 would be nodular masses, not only small nodules, isn't it?
Yes, sir.
Okay, so definitely it is not an indeterminate one. It is a likelihood of a complex cyst, which is going towards a malignant cyst, right?
Yes, sir.
Okay, so let's look into the next one. Here we have a lesion which is showing a sort of eggshell, all sorts of classifications, eggshell calcification, some amount of popcorn, some amount of specks of calcification within the tumor. And we are measuring the Hounsfield units as it enhances in the arterial phase, but it is not enhancing to that extent. And here you can see the if we take in the right phase, we can show to the surgeon that how the artery is going, how it's supplying, because all tumors may not enhance to that extent. The renal vein also can be shown very well in the venous phase, as is shown here. And here is the tumor that we can rebuild with a MIPT image for the surgeon, and it is quite exophytic, abutting the very renal structures, and it is being supplied by a branch as is depicted from here. It branches from the inferior branch as it bifurcates in the prehilar region. So this amount of information could be good for pre-surgical and pre-ablatory purposes. Here we can see the excretory phase, and we can really see that how the collecting system is being affected or not affected by the tumor. So renal mass, the rule of thumb is if there is no enhancement and if we are certain it's a cyst, then we go for a simple cyst classification. If there is macroscopic fat, then it is angiomyolipoma. If it is not macroscopic fat, we can look for chemical shift imaging and MRI that I'll be coming to for looking into a type of tumor where renal cell cancers also can have some amount of fat. Different malignant tumors can really have fat, but those are not detectable in CT. Enhancement, no fat, RCC or other tumor, if it is equivocal, 10 to 20 Holmes spindle unit, no enhancing lesion or pseudo enhancement, we have to consider MRI. Why? Because we might be missing an early lesion or a hypovascular lesion. Mild enhancement, RCC papillary is the most likely. Vivid enhancement, clear cell is the most likely. Differentials, oncocytoma, minimally fat, that is fat spared AML or fat spared AML in both RCC types. And that's how the management goes. That's better known to you. So we are not going into all these classifications. What we would be interested in is just to differentiate the primary types and not to miss out the hypovascular types. Patterns of enhancement, chromophobe cells, some people have published regarding the patterns of enhancement and differentiation of the types of tumors. But what is more important is we should be able to pick up the malignant ones and should not miss them out. Homogeneous is chromophobe cell RCC. Heterogeneous or predominantly peripheral is conventional, that is 84%, papillary 74%, and collecting duct is 100%, where there is heterogeneous and peripheral enhancement. Strong enhancement in the corticomedullary phase that I was talking about, more than 84, more than 114 Holmes spindle unit is one publication, and washout in the nephrographic phase is 66. So it is no longer about qualitative imaging. It's about quantitative imaging, and the radiologist needs to really sit with his images and measure and then tell that, yes, there is significant washout in a small lesion and it looks malignant in spite of the fact that in normal imaging, it might look really benign. So here we are, clear cell carcinoma, RCC, and its pattern of enhancement. You can see how it is intensely enhancing heterogeneously in the arterial phase. And just to show you that how the kidney of the rest of the kidney really enhances. This is the tumor. And in the nephrographic phase, it washes out, and it is going towards the renal vein as well. Papillary renal cell carcinoma can mimic clear cell renal carcinoma. Small tumors are hypovascular with enhancement up to 20 Holmes spindle unit only. Hence, contrast enhanced ultrasound and MRI may be required. So we'd skip some of these lesions. Of course, this lesion, if we just have the upper three images, we might think that this is a cyst, but unless we see the Holmes spindle unit within the lesion, we will not be able to pick it up. In these cases, these are renal cell cancers. And this, of course, looks heterogeneous in contrast to the upper line images, which do not look that bad. This is a conventional RCC where we have to stage the lesion as to how it is involving the capsule, how it is involving the surrounding fascia, whether it is going into the collecting system, into the vein, and then stage the lesion. These are truly hypovascular lesions. One of the important things we have learned in radiology is if you see a calcification somewhere, which is not fitting into the diagnosis or the size of the lesion, then put your suspicion into it. Here is a small calcification. Look into it is seen well within the lesion, and the lesion looks almost equal to the renal cortex in non-enhanced CT. In the arterial phase, you can see the arterial phase. It shows a pattern of peripheral enhancement with small nodules, enhancing strands of tissue or septa going inside. And then in the nephrography phase, you can see the enhancement, which is quite irregular, with some areas being spared. These are some hypovascular lesions. Here again, we can see another tumor, chromophobe tumor, which is showing calcifications, but it is also looking more like a cystic lesion. But when we go for enhanced CT, a protocolized enhanced CT, we are able to pick up that some amount of capsular enhancement, small nodular enhancement is there, but it appears to have all washed out. The arterial phase was quite enhancing and it has really washed out. Now, why does this really happen in tumors? It is a character of most of oncology studies that's why perfusion, CT perfusion has come into the recent imaging protocols. CT perfusion really helps us in case of lesions which are very small, one. Second is the lesions which are not really obvious in terms of vascularity. In those cases, we can measure it and quantify the amount of enhancement and the washout. This really gives us an information regarding the arteriovenous shunting that occurs when we are looking into malignant tumors. And this is also a character in case of renal and urological tumors. Dual energy CT is the new technique that is being used, where we take two sets of images using two energy levels, and the two energy levels give us two different sets of images with two different Hounsfield units. And these two different Hounsfield units can really help us identify some tissues. And it really is helping us, and it is coming up technique, and it will help us differentiate between small, benign, and malignant lesions in future. So you can see the sensitivity and specificity for perfusion CT compared to multi-phase CT. So we are in future going to see more CT perfusion. It will take time, but smaller lesions won't be missed. MRI in renal tumors. Now, the thing that has come up is a multi-parametric MRI. This term, I think most of the students of radiology are nowadays well acquainted with. So as I'm speaking with urology students, I think you also should be understanding that a multi-parametric MRI is an MRI with multiple parameters required for characterizing tissue. That is most important. Now, what is a T1 imaging? Just know that it will give the gross identification of tissue characteristic. T2, it will give identification of how much amount of fluid is there. MRI is all about playing with hydrogen ions, that is water. So T2 is going to give you identification of how much amount of fluid is there in the tissue. Diffusion imaging, diffusion weighted imaging is going to give you an idea about the ion exchange across the membranes. Try to understand in your urology chamber, if 5 people are sitting, there is some space for air. If tomorrow 20 people are sitting in the same chamber, there is less space for air. Less amount of water diffuses between the cell membranes to the interstitial space, and diffusion weighted imaging is all about that. Malignancy leads to crowding and loss of interstitial spaces, and that's why the signals are changed. This is an indicator of cellular increase as well as membrane permeability. Number 4, this is dynamic contrast enhanced images. Now, what is dynamic? Dynamic is we are trying to trace the flow of contrast in the tissue in a dynamic phase, start from the initial phase, arterial to venous to portal venous, and then to the delayed phases. All image sets are set in the data. Within the data, there are thousands and thousands of images. Nowadays, per CT has huge amount of data. Now, what is the use of this data? This data is useful for the radiologist who needs to sit with it and then really give you the information that you need and miss less. Chemical shift imaging for macroscopic fat, that is very important. Here, we need to understand that macroscopic fat is not missed. It is even seen in CT, and in MR as well. But microscopic fat, where we need some chemical shift imaging to identify small amount of fat. Why identifying small amount of fat? When very microscopic amount of fat, because these are characteristics of some tumors. So I believe we are able to understand what does multi-parametric MRI mean. So anybody has any doubts? Let's clear it right now, then we'll move ahead. Okay. So distinguishing MR features are very important. That's why we were trying to trace microscopic fat. Clear cell CA, microscopic fat is present. So in and opposed phases have to be carefully examined and seen in the protocolized images, so that we are able to trace that amount of fat and say that this is more likely to be malignancy, is not a benign lesion like AML. Papillary lesion, there is evidence of hemosiderine, which is signal loss on the in-phase images. Here again, chemical shift imaging. So this is helping us in identifying minimal amount of residue of hemorrhage, which was not identified in conventional imaging, be it CT or MR. Chromophore, where there is intermediate signal intensity on T2 weighted images. This is important. It will look quite benign, but the enhancement pattern is different from the other ones. But all is not very specific. However, the commoner types need to be seen and all sequences need to be evaluated. So here, if we just put aside the diagnosis, let us look at the lesion. This lesion looks iso-intense to the kidney, almost iso-intense, a bit hypo-intense you can say, but in the enhancement phases, it looks a bit, this is T2, so it is showing some amount of cystic areas. Now, as in the enhancement phases, you can see the enhancement pattern. Now, what is more important is, if we look at this lesion, there was a space which was enhancing in the nephrographic phase, but it was not as enhancing, so it is a hypovascular lesion. But if we look at the diffusion of the image, it shows clear restricted diffusion. Excuse me. So this restricted diffusion really adds to the information that the tumor is malignant. It is not a benign one. So hypovascular RCCs sometimes really papillary RCCs may show this pattern of enhancement, the small specks of fat, and can add information where it was looking as obviously benign lesion, but the multiparametric images being evaluated with all the parameters can really give us an information that it is a small malignant lesion. So this is for students. Anyone can pick up? a day before yesterday's image.
Some students should volunteer, please. It's a very
Is
interesting
anybody?
session.
Just is an interaction.
Anand, please go ahead. Support.
Okay, so let me just explain. This is a non-contrast CT. So we can see a fairly large tumor here. Now what we can see here in the non-contrast CT appears to be spared renal parenchyma, but that's not. It is the perirenal space where there is a collection which is fairly hyperdense, and it could be blood. And the tumor, it appears to have gone into the vessels. This is a huge tumor in a pediatric patient. So, and we can show the MIP images where we can show the arterial tree, and it is relatively hypovascular lesion, not enhancing to that extent as we can compare with the renal parenchyma. So it was possibly a Win's tumor, and though it hasn't crossed the midline, it has definitely invaded the renal vein. And the same patient has a metastatic nodule in the right upper lung. Now, what I was talking about is the Bosniak classification for students. Please look into the 2019 version, which has undergone a bit of change. Previously, it was purely a CT-based classification. Nowadays, MR has been added to it, though ultrasound hasn't been as yet. But some changes have been made into the classification for ease of classifying tumors, because some tumors have been found to be really benign, but they were in the 2F section, and they had really caused some confusions with calcifications and all. So in the 2 section, in the there are 6 types: cystic masses with thin less than 2 mm and few 1 to 3 septa. Homogeneous hyperattenuating, that is hyperattenuating lesions, 70 Hounsfield unit looking like hemorrhagic cysts, they are all 2. Homogeneous non-enhancing, more than 20 Hounsfield unit as renal mass protocol may have calcification of any type, that is 2. Homogeneous masses 9 to 20 at non-contrast CT. Homogeneous masses 21 to 30 at portal venous phase CT. Homogeneous low attenuation masses that are too small to characterize, all in 2. Then 2F, that it has gone a bit of change. Cystic masses with smooth, minimally thickened 3 mm enhancing wall, or smooth, minimally thickened 3 mm or 1 or more enhancing septa or more, that is more than 4 smooth, thin enhancing septa. So this 2 and 2F are very crucial in this new update, and we are following the same. So this is just a demonstration of how a 2 mm, 3 mm, 4 mm, and 1 mm thickness of the cyst wall can really change the classification. This is taken from a publication in version 2019 in last year. So these are the 3 and 4 features. You can see the nodules, mural nodules here, and the 4 features where there are multiple septa, being it more complex with the nodules. So with thick calcifications, 2F in current classification, and in the 2019 update, it has been in the 2 classification. This case was unchanged for 11 years. Bosniak 2F in CT, Bosniak 3 in MRI. This is another thing that we need to understand, how it changes, as we have seen in the classification. So please look into the classification and compare the changes that it has undergone since the last one. So category 3 histopathology is a cystic RCC. Here you can see the smooth enhancement, though it is smooth, but the thickening is a bit more. The initial arterial phase does not show the enhancement, but the later phases do show hyper-enhancing walls, and it is cystic RCC. cystic renal masses. I'll not go into the algorithm. So for students, what protocol from all that we have shown, what protocol for a suspected cyst or SOL in case it is in the kidneys identified in ultrasound? It is multiphasic CT or multiparametric MRI. Now, you may ask as to when multiparametric MRI. One, in cases where CT is not possible due to multiple reasons, renal compromise and all that. In that case, with consent, if it is just mildly compromised, we can put some gadolinium to the benefit of patient's diagnosis. And in that case, we can go ahead with a multiparametric MRI. That is one. Number two is in case of hypovascular lesions, where the category of the lesions can change with multiparametric MRI, or the identification of smaller lesions where they are suspicious in multiphasic CT, but they may need a bit more characterization considering the size to be less than 3 centimeter, less than 2 centimeter. In that cases, multiparametric MRI might help. How does a cyst look like in CT? That you know from the last few slides. It looks like water density in CT with a very thin, imperceptible walls. Which lesions show fat in CT? Commonest, please tell me.
Angiomyolipoma.
Angiomyolipoma.
Fine. So, and of course, in other lesions, do you see in any lesion a scar? That is very important in differentiating it from a malignant lesion. Can you name any lesion? Oncocytoma. So centralized scar is seen in 30% of the cases, and we should definitely look. How does a scar look like?
Stellate scar, sir.
Yes, central stellate scar.
Does it enhance in the multiphasic CT? It
No,
will
sir.
not enhance. You have to put the attenuation value in the scar in the non-enhanced scan and then see simultaneously in all the enhancing phase and then come to a diagnosis that it is likely to be a scar. Else it might be a centralized hypovascular peduncle of the tumor itself. So it is sometimes dicey to diagnose an oncocytoma where we might miss a RCC as well. And which lesions do show calcifications?
Renal cell carcinoma can show, sir.
Yeah. Anything else?
Capillary.
Anything else can show?
If it is infective, also it will show. So infective.
Yes,
Chronic
yes,
pyelonephritis.
yes. Most importantly, a chronic abscess can also show calcifications. Now, which is a better modality, CT or MRI? That's a very common question that's being asked to me.
CT, sir.
This is the easier modality, lesser time, and we can answer most of the questions. And we'll discuss as to what are the we have already discussed what are the preoperative requirements in imaging. Now we'll go to the prostate cancer. Here again, multiparametric MRI. And we are following the prostate imaging radiology data system that we are using for reporting and data system that we are using, the version 2.1. So what it is again the same thing. T1, T2, DWI, DC, what we were talking about. T1 is the morphological imaging. T2 is for identification of water. DWI is for diffusion imaging, and DC is for the contrast enhancement. And we all try to put the lesions, be it small or large, into the different sectors that we are doing. The sectors are very important in identifying the lesion's location by both the surgeon as well as the biopsy, as well as while doing the biopsy. So it is important that the lesion is being defined in terms of the sectors. So now 41 sectors total, 38 prostate, 2 seminal vesicles, and 1 is the membranous urethra. So I'll not go into details of pyrids. That is very common thing what we need to understand, how do we score it? A normal appearing transitional zone or a round, completely encapsulated nodule is a typical nodule. A mostly encapsulated nodule or a homogeneous circumscribed nodule without encapsulated is an atypical nodule. So we need to understand what is a typical or an atypical nodule. And if there is a linear or wedge-shaped hypointense lesion, but it really shows some restriction in diffusion, it might be a lesion that is more likely to be a malignant or a pyrites highly scored, high score pyrites. In that case, we need to take it into account. This is the algorithm that we follow. If it is a pyrites 1, where as soon as up to pyrites 2, it's these lesions are mostly to be just followed up. Beyond that, as it goes into the dynamic contrast, if it is not enhancing, then it is in the peripheral zone score 3. And if it is dynamic enhancing, then it goes to pyrites 4. Diffusion, if it is less than 4, ADC has to be measured. If it is less than 4, then it is O3. If it is 5, then it is pyrites 4. So pyrites 4 is highly likely of prostatic cancer, and pyrites 5 is very high because that has already involved the surrounding structures. So we'll not go into all these details. So this is the normal algorithm. Pyrites 1 is highly unlikely. Pyrites 2 is unlikely. Pyrites 3 is equivocal. Might be we need biopsy where it is not matching with the PSA scores, or it is not matching with the clinical parameters. In that case, we do biopsy. And 4 and 5 to be confirmed with histopathology. Here we find a lesion which is on the left side. There is another lesion which is showing some amount of enhancement, but this is a lesion which is hypervascular, but in restricted, this is an ADC image, it is showing quite high restriction. So this is quite high pyrites lesion, and the lesion is peripheral subcapsular in location, and we will definitely assign it to a particular area. On the other side as well, it is showing some amount of restriction. Here you can see, though this is a transrectal coil that was being used previously, nowadays we do all in the pelvic coil. So here we can see a large mass occupying the prostate, and this is the diffusion image showing the restricted diffusion. So this is the tumor, which is pyrites 4. Similarly, here you can see some lesions which are T2 hypointense. First thing that we need to see is the T2 image. So a T2 hypointense in the anterior and posterior transitional zone sectors in the mid-gland level. So this is the lesion which is showing restriction in DWI as it appears hyper intense or white in the DWI image and shows restriction in the ADC image. More importantly, there are some hypo-intense lesions on the left side of the transitional zone, which is showing restricted diffusion in DWI and obvious restriction in the ADC image as well. So these are all pyrites 4 lesions. I have not shown you the DC image in this case. Similar cases where restriction might be helpful and where dynamic contrast might be helpful and a washout can be traced. Here you can see the early pickup of contrast. It is enhancing intensely on the right side and slowly it washes out. The latest thing that is coming up is accuracy of targeting smaller nodules. So we already have a competent machine, but we don't have the tool as yet.
लिमिट होता है ना पढ़ाने ना उतना तक उन्होंने
tool soon, but it is very important that the ultrasound truss image while doing the biopsy should be accurately matched with the MRI diffusion image. Here you can see a diffusion image, MRI diffusion image target being used in fusion MRI and truss for the biopsy. Here is the lesion, and you can see the needle inside that has been reconstructed. So what protocol for an MRI prostate? it is multiparametric MRI. Yes, TRUS does hold an important value in diagnosing prostate cancer as well, because all people are not do not undergo multiparametric MRI. So TRUS has also a fair amount of sensitivity in picking up lesions, but lesions less than 2 centimeters in the peripheral as well as transitional zone with evidence of benign prostatic hypertrophy are low in case of TRUS. In that case, a multiparametric MRI really does help. So what are the imaging modalities? TRUS and MP-MRI. And what is TRUS and its advantages? It is fairly easy, though it is operator dependent, but anybody who is competent with doing transrectal procedures can do a transrectal ultrasound and well can identify a fair amount of disease. And it is an excellent tool for following up disease as well if we use Doppler along with TRUS. So let us move on to bladder cancer. Do I have 10 minutes? Okay, I'll just try to
yes,
wind up as early
just
as possible. Okay, so non-muscle invasive bladder cancer, that is non-invasive papillary CA, and TIS is non-invasive carcinoma in situ. T1 is invasion of the lamina propria. We are not concerned with NMIBC. We are concerned with MIBC because that is an area where if we miss, it really makes the management changed. So T2A is invasion of the inner half of the detrusor muscle. T2B, invasion of the outer half of the muscularis propria. T2B, high risk for lymph node metastasis, that is 14 to 30% respectively. Hence, it is very important to score the disease. Hence, we have come up with multiparametric MRI for bladder cancer and the VIRAD score, vesicle imaging, radiology, report and data system, reporting and data system. So VIRAD score is now being given and it really helps in characterizing it or scoring it or staging the stage of the tumor. So local staging, VIRADS one is muscle invasion is highly unlikely, where there are only structural changes, contrast enhancement and diffusion weighted category 1. We will not go into the details of each of them because that is a lecture in itself. It's quite vast. VIRADS 2, muscle invasion is unlikely to be present. The structural category is 2, 3, contrast enhanced and or diffusion category is 2. VIRADS 3 is presence of muscle invasion is equivocal. VIRADS 4 is muscle invasion is likely. VIRADS 5 is invasion of muscle and beyond the bladder is very likely. So this is the simple diagram that is describing VIRADS 1 to VIRADS 5. Here you can see the VIRADS 5 lesion where the black line in T2, the T2 black line which characterizes the outer muscular layer is being breached and the tumor goes beyond that. We have to look very carefully for VIRADS 4 lesions where the inner muscle layer is invaded, but it is enhancing and is not going beyond the muscle layer. So here we can see one of the lesions. If you can appreciate the image, though it is a bit dark, the muscle layer, black muscle layer can be seen here and it can be traced right into this area. The diffusion image is pretty bright. So this is a malignant tumor, no doubt about it. The dynamic contrast enhanced image shows the muscle layer to be enhancing. So there is possibility of muscle layer involvement. If you compare it with the rest of the bladder, it is not enhancing to that extent. So it is muscle invasive cancer. So what are the imaging options for suspected bladder tumor? Multiphasic CT that we have been following for so long. I thought of just apprising you of what multiparametric MRI can add over the CT. CT we have been seeing hyper-enhancing or sometimes hypo-enhancing tumors, and we look for perimural fat stranding. We used to look for perimural fat stranding. But nowadays we are more equipped in MRI, and we are able to say, yes, definitely the muscle layer is breached or the muscle layer is involved. So it definitely helps detect muscle invasiveness and thus guide treatment. So that's about the common imaging for kidney, prostate, bladder. 3 things I tried to cover. If you have any questions, please do come up.
Hello, sir. Good morning. It's
Good
Dr.
morning,
Benu.
sir.
How are you, sir?
So fine.
It's a very exhaustive and a very nicely elaborated topic that you have discussed. Very nice. One thing I have query.
Yeah.
In diagnosing renal tumors, which investigation you will appreciate more? The most, what I want to say, the most diagnostic, which will choose?
CT.
CT, not MRI.
Renal CT protocol, renal tumor
Yes.
protocol CT, proper protocolized. That is the investigation
That
of
is the
choice.
best
Till now, that is
investigation
enough.
for staging and etc. and follow up.
Yeah, yeah, yeah,
Okay,
absolutely.
sir. And sir, for bladder tumor, sir?
Bladder tumor, nowadays there is a controversy between CT and MRI.
MRI,
Because,
exactly.
yeah, the question is muscle invasive bladder cancer is a big debate in even in radiology, uroradiology circles, because this is one thing where we are not really able to comment much in early invasive cancers in CT. That's why people are now saying that BIRADS is a better protocol, just like MR of prostate took up, right, in comparison with other modalities. So it might take up in the future.
Okay, thank you. Thank you. That's nice. Very good topic, sir.
Thank you.
Thank you, Dr. Rai Chaudhary. Thank you for the lecture and enlightening us. Now I'll hand over the session to Dr. Anirban Mukherjee, who is a consultant radionuclide study. He will be giving us a brief idea about the radionuclide materials and studies which are being practiced in urological diseases. Thank you. Anirban, to you.
A very good morning, and after such an exhaustive and an excellent lecture by Dr. Hirokawa Chaudhary, I think I should make it very short and brief because the time is constant is there. So today we will discuss about the basic applications of nuclear medicine in the United States.
Anirban, just to interrupt,
yes,
can you speak a little louder?
Yes, sir. Yes, sir.
Thank you.
Can you hear me, sir?
Yeah, it's a little bit. I mean, can you bring the mic a little closer?
Is it audible?
It's clear.
Huh?
Yes, clear.
Yeah.
Yeah. Today we will discuss about the relevant application of nuclear medicine. So first we will just go through the basics of the nuclear medicine, that divide the nuclear medicine procedures into 2 parts in case of when we talk about the imaging in the United system. That is the gamma imaging, that is GTPA and DMSA scan, which are most popular nowadays, and the positron emission imaging, which involves FDG PET-CT, which is used in renal cell malignancy, bladder malignancy, and also the new entrant, which is very popular now, that is the PSMA PET-CT, which is used in the case of prostate malignancy. So coming to the gamma imaging in urinary system, we usually use this for 2 types. One is to assess the dynamic function of the renal, and also to find out the cortical function. So to assessment of the dynamic function, we mostly use DTPA renal scan or the EC renal scan. For the assessment of the cortical function, we use DMSA. So this is a kind of normal dynamic renal scintigraphy. I will just go into the basics, that we prepare the patient. Patient is lying down on the table, and then we put the camera posteriorly because the kidney is situated posteriorly. Now, these initial parts of images are the flow images. It represents renal perfusion. So when we inject the radiotracer in the peripheral vein, it first enters to lung through the SVCs and the right side of heart. Then from the right side of heart, it comes to the left side of heart, and from there you can see this aorta coming down, and from aorta kidney takes up the radiotracer. So these first two sets of images are the perfusion images. After that perfusion images, what its kidney starts? It starts excreting the radiotracer into the urinary bladder through the ureter. So this is by these two sets of images, we form this kind of dynamic renal curve. This is called renogram curve or dynamic renal curve. Now, what happens initially when we inject the radiotracer, the count in the kidney starts increasing because it is extracting the radiotracer from the blood, and then what happens at the point of time, it becomes a plateau where the rate of extraction of radiotracer from blood is equal to the rate of excretion of tracer into the urinary system. Then what happens in case of non-obstructed normal kidney, the rate of extraction increases more than the rate of extraction from the blood. So rate of excretion is surplus. So then the count in the kidney becomes low. So this is how a normal renogram curve looks like. First, there is a peak which implements the perfusion phase. Then at around 2 to 3 minutes, the peak is reached. And after that, the count in the kidney decreases. So this is kind of a normal renogram curve in case of normal non-obstructed kidney. So these are the few parameters which are used to find out that whether the kidneys are obstructed or non-obstructed. So this is the perfusion percentage. This is the time to peak. Now this time to peak should be between 2 to normal is 2 to 3 minutes. So here both the kidneys peaking at 2.66 minutes. That means it is the normal perfusion. Next is peak to half peak ratio, which is, and then this is a 20 minute to peak ratio. This is 0.15 to 0.16, and then 20 minute to 3 minute ratio. This 20 minute to peak ratio and 20 minute to 3 minute ratio should be ideally less than 0.3. And there is another thing called diuretic T half, that is the peak to half peak. It is 4 minutes in these both the kidneys. So ideally it should be less than 10. If it is 10 to 20, then it is called intermittent obstruction. And if it is more than 20, then it is called obstructive kidney. So this is what we told you about now is that normal renal scintigraphy. Now we use diuretic renal scintigraphy for the assessment of hydronephrosis. Now why diuretic renal scintigraphy? Because there are sometimes confusion between the functional stasis and the anatomical obstruction. Now to alleviate this confusion, we use LASIK. Now what does LASIK do? It increases the urinary flow. So if there is a true anatomical obstruction, then there will be much more accentuation of the obstruction. So the tracer will not be washed out. But if there is a functional but if there is a functional washout or functional stasis, then there will be a washout of the radiotracer. Now this is a image showing that this is the case of functional stasis. Now this is left kidney, this is right kidney. Now you can see this blue line is representing the timing of administration of LASIK. Now initially there is an accumulation of tracer in the pelvic calcial system. Now look at around 10 minutes the LASIK is given. Now here the LASIK is given. So after that there is a wash out of the tracer from the left kidney. So there is an washout of the tracer from the left kidney seen. So this is a case of the functional stasis. Whereas this is a case of true anatomical obstruction. This is an F0 protocol. I will come on the timing of the LASIK injection. So even after the injection of the LASIK, you can see there is a continued accumulation of tracer in the right kidney. So there will be a gradual upward movement of the renal renogram curve, and this is called a true anatomical obstruction. Now these are the few controversies are there regarding the dynamic renal scintigraphy, especially the diuretic renal scintigraphy. Now the patient should be adequately hydrated. Now, what hydration is to be used, oral or IV? Now, in most of the cases, oral hydration is sufficient. In case patient cannot take water or is vomiting or something like that, then you have to do a IV hydration. Now, what radiotracer to be used, DTPA or EC? Now, in the child, the glomerulus is not mature. Now, what is the difference between these two radiotracers? The DTPA is the glomerular filtrating agent and EC is the tubular secreting agent. So, in child, glomerulus is not mature. So, in child, the preferable radiotracer to be used is the EC. Less than 5 years of old child, preferable radiotracer to be used is EC. In adult, we can use both DTPA and EC. But if you want to know the GFR, then it is better to use DTPA because EC gives a completely separate parameter that is called ERPF or effective renal plasma flow. So next is the coming to the timing of furosemide injection. Now these are the three protocols which are actually well documented in the literature. That is the F+20, F-15, and F0. Now what does this mean? F+20 means that you inject furosemide 20 minutes after injection of the radiotracer. Now F-15 means you inject furosemide 15 minutes before injection of radiotracer. And F0 is you inject furosemide along with the radiotracer. Now, how this differentiate between each other? That in the first protocol, what happens that you give kidney time to do its own function. If kidney cannot clear the radiotracer on its own, then you inject furosemide after 20 minutes. Thereby, you obviate the need of the adding another drug if kidney is functioning normal. Now, F-15 is what? That it is specifically preserved in case of the equivocal pattern or in case of post-pyeloplasty. Now, why this protocol is based is that you inject furosemide 15 minutes before the injection of radiotracer. Now, the lactic in the furosemide has peak function at around 10 to 15 minutes. So, when we inject the radiotracer, the kidney is under maximal diuretic stress. So, then what happens? So, this is the base protocol when you try to find whether there was a equivocal pattern in earlier scan or whether there was a post-pyeloplastic cases. This is the protocol to be used, that F-15. And F0 is specifically reserved for the children. Why? Because in F0, what we do, we mix both Lasix and radiotracer in a single syringe and inject it to the child. So thereby, in children, the multiple injection is difficult. So this F0 protocol is typically preserved for the children. Next, what we have to do, bladder catheterization or not? So bladder catheterization is only indicated in patients with a bladder reservoir effect. Suppose in case of neurogenic bladder or in case of PUV. So in these cases, we recommend to do bladder catheterization in this patient. So these are the type of renograms which you usually read in the book. This is the normal one. We have already discussed this normal one. Then this is the obstructed, which shows the anatomical obstruction. This is also we have discussed. This is an hypotonic pattern. This is typically found in case of functional stasis. This is also we discussed that after diuretic, the graph become down. Now, in always there is an equivocal pattern that is between the normal type or obstructed type. So here the ideal protocol to be used is the F-15 protocol. And then this is called a delayed decompensation type. That is the type 4 type of diagram. Now this is also known as Holmes' sign. Now let me take a few minutes to describe this. That after the injection of diuretic, there is initially the curve goes down. So that initially there is a clearance of radiotracer from the kidney. Then it starts increasing again. Now this is a sign of impending obstruction. Now what happens? Suppose if there is a pipe of water, it permits the flow of water at 10 ml per minute. Now, if the flow increases to 20 ml per minute, now what will happen? That the flow will get obstructed. So similar thing happens there. So initially, when there is a initial phase of diuretic, the flow is increasing. So it still permits the flow through a narrow channel. But when the diuretic function increases, I have said that the maximal diuretic stress will be after 10 to 15 minutes after injection of diuretic. So when the diuretic stress is increasing, the flow also increases. So in this high flow, the already narrowed system collapses and there will be a proximal obstruction. So this is kind of delayed decomposition pattern is found in a case of impending obstruction. If you don't intervene in this kind of curve, then it will obviously lead to this kind of curve, ultimately obstructed type of curve. So coming to the decision based on renogram. Now, if this is a non-obstructed pattern, presented a hydronephrotic kidney, you find it is a non-obstructed pattern, then it should be conservative with serial follow-up with ultrasound. If there is an increasing in the epidiameter and decreasing parenchymal thickness in the ultrasound, you can repeat the diuretic renogram. If this is an obstructed pattern, now then goes to the differential function. If differential function is less than 35 to 40%, then we should proceed for the surgery. If differential function is less than, if more than 40%, then it should be conservative. Then by follow-up with the ultrasound, increasing in the epidiameter or decreasing in the cortical thickness, then repeat diuretic renogram. If there is a fall in the differential function more than 5 to 10%, then you can consider surgery. Apart from the decision making about the surgery, DTP renogram also have some prognostic effects. That is, less than 30% differential function is associated with the poor surgical outcome, and it is also useful in the follow-up of the patients of pyeloplasty after 6 to 9 months. Now, this is what we talk about the diuretic renogram. Now we will talk about the renogram where diuretic is not required. Now, this is in case of renal transplant. Now, in renal transplant, DTP renogram serves two purposes. One is to serve the donor. In donor kidney, DTP renogram is the only investigation of choice which gives you a single kidney GFR, because all other modalities will give you total GFR, but DTP is the only modality which gives you a single kidney GFR. Now, why this single kidney GFR is important? Because the kidney which has less GFR is to be transplanted. So that is why DTP renogram is important for the renal transplant, for donor evaluation in renal transplant. And in case of recipient evaluation, it is helpful in evaluating between the ATN and AR. Typically in the post-operative 4-5 days, you see diminished urinary output. You want to rule out between the ATN or AR. Now, it is helpfully in differentiating between the ATN and AR. What happens in ATN? That in ATN, the perfusion in the kidney is preserved. You see a very good pressure uptake in the kidney, transplanted kidney, but there will be no excretion. So this is typically a hallmark of ATN. But what happens in AR? That the perfusion in the kidney is impaired. So you can see there's a very less perfusion in the kidney. So in AR, the perfusion is also impaired, and also the excretion is also impaired. So next, urinary leak or the perinephric. We should say this is the evaluation of the perinephric collection. Whether this is an urinary leak, whether this is an hematoma, or whether this is an lymphocyte. Now, since this is DTPA goes into the kidney, so it will be excreted through the urine. So if the perinephric collection has same radiotracer density as the kidney, so we are possibly dealing with a collection that is an urinoma or urinary leak. So you can see that the collection has almost same density as the kidney. Whereas in case of hematomas or other things, there will be a photopenic defect, because there will be a collection which will not contain the radiotracer, because the blood or lymph will not contain the DTPA. DTPA will be only present in the urine. So if there is an urinoma or a suspected urinoma, or you can suspect any other collection, you can also perform DTPA scan to find out the nature of the perinephric collection. So now next, coming to the DMSS scintigraphy. Now this is a normal DMSS scan. So this again a left kidney. This is again the right kidney. We also found this is left posterior oblique view. LPO means this is left posterior oblique. This is mainly to evaluate left kidney, and this is right posterior oblique view. This is mainly to evaluate right kidney. Now, what is the DMSS used for? Is mainly used in the indication of UTI to find out. So there are two phases in UTI where you can use DMSS scan. One is acute DMSS. This can be used in the 48 hours of UTI. Now, this is helpful in diagnosis in the equivocal case of pyelonephritis. If acute DMSA is normal, it has a very good prognostic effect, then there is no chance of developing scar. Then there is a case called late DMSA scan that is performed 4 to 6 months of UTI, or in case of atypical UTI, or in case of recurrent UTI. Now, this is which looks like an acute pyelonephritis. Now, this is posterior view, this is anterior view. So, this is called the whole kidney will be decreased. The radiotracer will be heterogeneously decreased in the whole kidney. This is a classical description of the acute pyelonephritis. And this is for a chronic pyelonephritis, and where is the scar is developed. You can see this is the wedge-shaped photopenic defect in the midfold of left kidney. So this is a case of classic chronic pyelonephritis. But this is a very bookish definition. We hardly encounter this kind of pattern in the clinical practice. So what we will do, we usually do our dynamic DMSS scan to differentiate between the acute and chronic pyelonephritis. Now, what happens in acute inflammation, or in case of acute pyelonephritis, that is an acute inflammation. So in acute inflammation, that blood flow will be increased into that kidney, right? So if we do dynamic DMSS scan, then the blood flow in the affected kidney will be increased. But when there is a scar, so blood flow is already decreased in that part. So there will be no increase in the blood flow in that part. So if a kidney shows in a suspected case of UTI, if a kidney shows an increased amount of blood flow, so we possibly dealing with a case of acute pyelonephritis. And if the blood flow is decreased, then we possibly dealing with a case of chronic pyelonephritis. So what are the other indications of DMSA? Just to find out some congenital defects. This is a case of a horseshoe kidney, right? It is fused in the lower pole, and you can clearly see this is a case of horseshoe kidney. Now, this is an absent left kidney. Okay, so the left kidney is absent. So this is an other indication. This is a case of cross-fused ectopia, where the left kidney is fused to the lower pole of right kidney. So this is again an ectopic low lying right kidney. This is left kidney, posterior view, left kidney is normal in position, and right kidney is situated in the lower pole. Now this is another very common indication of DMSA scan. This is in a case of multicystic kidney. You find it in the ultrasound. And then what is the role of DMSA? So it could be a two types. It could be a multicystic cortical dysplasia, or it could be a polycystic kidney disease. Now, in multicystic cortical dysplasia, there is a complete absence of the DMSA uptake in the affected kidney. Whereas in case of the polycystic kidney disease, the DMSA uptake will be preserved, but it will be very much impaired. Okay. So whereas in the multicystic cortical dysplasia, there will be a total absence of the tracer uptake. Now coming to the very interesting topic, that is PSMA PET-CT. Now why PSMA PET-CT is important? Why not FDG? What is the harm of doing FDG PET-CT? Now this is a scan which is showing that why PSMA PET-CT is important. So you see, this is the similar done in a similar patient. This is the prostate nodule. You can hardly see it in the FDG PET-CT. In the MIP image, you will not appreciate it. In case of cross-sectional imaging, you could hardly see a uptake there. Whereas in case of PSMA PET-CT, look at these images. You can easily appreciate these images, and so that is why PSMA PET-CT is indicated, because FDG has very, very low sensitivity in well-differentiated prostate malignancy. So what are the indications of the PSMA PET-CT? First is the characterization of the lesion. Second is the initial staging. Third is the biochemical recurrence, and fourth is the diagnostic course. So these are the different type of PSMA ligands. The most commonly we are used is this gallium PSMA and 18F PSMA. Now I will just go brief about this differentiation between these two, because it's important, because gallium based PSMA has kidney based excretion. Now what happens if kidney dominant excretion is there? There will be much more activity in the urinary bladder, which may mask the small lesions in the prostate, whereas 18A PSMA has liver dominant expression. So there is a very less radiofrequency in the urinary bladder. So the small lesion in the prostate will not be marked. So this is our basic difference between the gallium and 18A PSMA. So that is why now people are trying to move from gallium PSMA to 18A PSMA. So first, when PSMA appears, we are very happy that something specific for prostate has come out. But with time, we have found that PSMA is not so specific for the prostate. This is a list of case reports which you can see that this spectrum where PSMA is expressed. The most common we will find that in case of hepatocellular carcinoma, in case of renal cell carcinoma, in case of transitional cell carcinoma, PSMA is also expressing. So that is why you need to find out this characterization of the lesion by MI-PSMA score. Now, what is this MI-PSMA score? You found out 3 reference organs. One is parotid, one is liver, and one is blood pool. Now, why this is important? Now, if a lesion shows increased tracer uptake less than blood, then the MI-PSMA score is 0. If the uptake is more than blood but less than liver, then the MI-PSMA score is 1. If the uptake in the lesion is more than liver but less than parotid, then the MI-PSMA score is 2. And if the lesion uptake is more than parotid, then the MI-PSMA score is 3. Now, MI-PSMA score 2 and 3 is taken as a very characteristic of prostate malignancy, whereas MI-PSMA score 0 is considered as a negative, and MI-PSMA score 1 is considered as indeterminate. So next is coming to the other indications. Now, apart from this initial staging, what PSMA is also useful that in case of prostate malignancy, you have to do a multiple biopsy from the prostate, because prostate malignancy can be a multifocal disease and you need a 16 quadrant or 32 quadrant biopsy. So also PSMA is useful to guide you to the site of the biopsy, because the site where the uptake is, you can easily put a needle on that side and you find a very good result about that histopathologically. Now, what is the indication of the initial staging? Now, PSMA PET-CT is classically indicated in high-risk cases, whereas the Gleason score is more than 7, PSA value is more than 10, and more than 10 or more than 20, there is a controversy. If somebody says it's more than 10, somebody says it should be more than 20. So in initial staging is reserved for high risk and some cases of moderate risk patients. Whereas in case of low risk patient, PSMA PET-CT is not indicated. The local evaluation with the AMR is sufficient in case of low risk prostate malignancy. Now, where truly PSMA PET-CT plays a role is in this setting, that is in case of the biochemical recurrence. Now, what we will define as it is a biochemical recurrence, that after a radical prostatectomy or a radical radiotherapy, if PSA level is more than 2 nanogram per ml, or if it is after radical prostatectomy, it is increasing at a rate of more than 0.02 nanogram per ml, then it is called a biochemical recurrence, and PSMA PET-CT is the investigation of choice in this setting. Now, the people says that between 2 to 10 nanogram per ml of PSA level, PSMA is the only investigation to be done. If PSA level is more than 10 nanogram per ml, in case of biochemical recurrence I am talking about, then you can do other conventional imaging modalities like CT, bone scan also, because then the possibility of finding out the macroscopic disease is more if PSA is more than 10 nanogram per ml. But if PSA is between 2 to 10 nanogram per ml, then the possibility of finding macroscopic disease is less. So the higher sensitivity scan, that is the PSMA PET-CT, should do well in this setting. So this is the ideal indication of the PSMA PET-CT in case of biochemical recurrence. So thank you for all for your kind attention, and also thanks to the urological study for inviting me. If any question is there, please consider. Thank you.
Thank you, Dr. Anirban. Thank you for the elaborative discussion about all the radionuclides materials and studies we require in the urological practice. Now, I think the session is over, and I'll ask Dr. Devmal to hand over, take over for the instruments and other things.
Thank you, Vastudha. This was a very elaborate session, and it was really helpful for even junior consultants and younger consultants like us to go through this radiology session. So this is the time when we, am I audible to you? Hello?
Yes, you are audible.
Yes.
Yes. So this is the high time that we start with the instruments. Dr. Pramod Sharma, can you please unmute yourself?
Yeah.
So I hand over this initial session to Dr. Pramod Sharma. He will take up the lower tract instruments. So I also request one of the students, either Dr. Ashutosh Tiwari or Dr. Anand Biani or Dr. Ankit Sandhu or Dr. Dipankar Sharma to volunteer to answer his questions. And remember that instruments in your examination does not only discuss or score with the description of the instruments. The examiner tend to go to the surgical part as well, and he will also test you that whether you have all really seen the instrument or you have only gone through a textbook. Dr. Pramod Kumar Sharma, the mic is all yours.
Thank you, Devmal. Good afternoon, everyone. Now I will be talking about lower tract instruments. Am I audible to everyone?
Yes, you are. Yes, you are.
Screen is available. Screen is visible.
Yes, it is. Yes, it is.
So starting with the lower tract instruments. Are the students there?
Yes, sir, we are there, sir.
So Dr. Ankit, is he there? Dr. Ankit?
Yes, sir.
Yeah. So can you identify this instrument?
I'm not able to see the slides.
You're not able to see the slides.
So now it's visible, sir.
Yes, sir.
Now it's visible. Okay. Can you identify the instrument?
So this is a cystoscope, sir.
Is this a cystoscope?
It is a cystoscope sheath, sir.
Okay.
With an obturator.
With an obturator. So can you tell me about the formation of cystoscope? What are the parts of a cystoscope? To form a complete cystoscope, what other things will you require?
So we require a telescope and a bridge to complete a cystoscope.
Okay, but you will got something more. You also require a light source.
Yes,
Without a light source, it's not possible to visualize. Camera is optional. You might see it with the naked eye itself, but anyhow, you will require a light source to visualize the bladder. So, what are the different sizes of cystoscope sheath which are available?
So 21 French, 17 French, 19 French, sir.
Okay, this is that you should tell in a order like 17, 19, 20,
Yes.
it's 22 and 24. 21 is there. 22 and 24. How do you know the size of the cystoscopy sheath? How do you identify which size sheath you are getting in the exam?
There will be number marked on the, sir, the in between the two, sir, what outlet and inlet, sir.
There is an engraving. The sheath
Yes,
size
sir.
is engraved. Besides this, any other way? If like it's the old sheath, then this engraving has been wiped off, and will you be able to identify? There is some color coding for it, isn't
So there is a color disc which is present along with every sheet, sir.
Yeah. So, can you do you remember the color? Can you tell me the color codes? Which is the most commonly sheet used in your institute?
So it is the 17 French cystoscope, which is yellow in color,
Okay.
which is most commonly used.
Usually we use 70 French, and other which we commonly use is 20
Others
French.
are found to be, so
20
20 French is red.
Yeah.
And 25 we are sometimes using, which can be seen here, is white colors.
White. This is 25. This is white. So on the eyepiece end of the sheet, there are certain engravings there. Can you see that? One of those which you told is the sheet size, after that, there are two other things which are mentioned, which are marked over there. So what are those? What are those markings for?
This is the diameter of the instrument that can be passed through.
Sir,
there are two sets. Okay, there is a marking with a single circle with the marking, and the number is mentioned. This is the largest size of accessory instrument which could be passed through the sheet. And then below that there are two numbers that were engraved, and these are, if we simultaneously pass two instruments, the maximum size of the instrument which could be passed. If we are trying to pass two instruments or two ureteric catheters, the maximum size which could be passed through the sheet is mentioned over there. Okay. So there are certain markings on the tip of on the sheet, shaft of the sheet as well. Okay. So what are these markings? How many markings are there?
So the total length of the cystoscope is actually around 22 centimeters. And after 10 centimeter, the marking is being done, which is going to be 1 centimeter apart. And total, we are having around 13 markings, which
13
are
markings
there.
are there,
12 markings, which are there.
So why are these markings there?
So this actually helps us to measure the prostatic urethral length, sir, while we are doing the cystoscopy.
Beside this, there is another diagram over there, another picture over there. Cystoscopy beak, which is shown.
So it is a beak, sir. Yes.
Yeah, beak. So do all the cystoscopes have the similar beak?
Sir, actually, the beaks are of two different types, sir. One is going to be a short beak and the other is a long beak, sir. Apart from the 17 French cystoscope, which is having a short beak, all others, which are 19 and apart from that higher versions, they are having a longer beak, sir, which is associated.
So why does 17 French sheath has a shorter beak?
So normally 17 French cystoscope sheath is having, so they are best suited for the female cystourethropy. It is having a short beak, which is helping us, it will help in the fluid irrigation
visualization of the short urethra.
Yes.
Short urethra.
Short urethra, sir. Female.
So it would not egress out from the urethra, and it can descend the urethra. The shorter beak can descend the urethra, and the urethra can be better mobilized. Okay.
Yes, sir.
So what is the material with which the cystoscope sheaths are made?
So stainless steel, sir.
This surgical grade stainless steel with the material used for making the cystoscope sheath. So now, Dr. Anand.
Yes, sir.
Dr. Anand, yeah, you're there. Yeah. Can you identify this instrument?
Sir, this is a cystoscopic bridge, sir. And there are three varieties which have been shown, sir. One is without any working channel, the other is with a single working channel, and the other is with two working channels, sir.
So what is the maximum size instrument which can be passed through the double accessory channel cystoscope sheath bridge?
So it's a 5 French which can be passed through. So.
Actually, this bridges are standard. The maximum instrument which can be passed is decided by the sheath. The sheath which you are using along with
it will be decided by the sheath, sir.
Yeah, it's not by the bridge. It's decided by the sheath which you are going to use. Okay. There is one more type, that is cystoscopy sheath bridge.
Albaran's bridge, sir. Yes.
Yeah, Albaran's lever. With Albaran's lever. What is Albaran's lever?
So it is actually having a lever which is helping to deflect the ureteric catheter inside the bladder, sometimes to make it to align it to the ureteric orifice,
so
and which can be almost deflected to about 90 degrees or a better. Yes,
so the fourth type is Albaran's lever. The Albaran's lever, that is the lever. There's a lever on the vesical end of the bridge, with the help of which we can deflect the tip of the that rod, which is there. With this we can deflect the ureteric catheter so as to easily negotiate them into the ureteric orifices. Now, third one. Can you identify this? Hello, Dr.
Okay, hello.
Dipankar. Dipankar, are you there? Dr. Dipankar?
Yes, sir. I'm here, sir.
Yes,
Yeah,
sir.
yeah. Can you identify this instrument?
So this is the lens, sir. This is the
Lens.
cystoscope lens.
Be proper. You should be proper while answering such questions. Okay. The telescope. This is a
It is a telescope, sir.
4 mm. Yes. Then what? 4 mm. 30 degree.
Rod lens telescope, sir.
30 degree.
Rigid telescope.
30 degree telescope. So how do I know this is 30 degree?
So by the color coding we will know, and with color coding we will know, sir. And
Where do you
also it
find-
will be mentioned on the scope. Telescope.
Where do you find the color code?
So on the base of the light pillar, sir.
With the right pillar, there is a red ring which you can see. This denotes that is 30 degree. So what are the different with a different type of telescope which are available?
So one is rigid and other is flexible.
No, only the
and
rigid,
other than
rigid,
that,
I am talking about the rigid ones.
so there can be 0 degrees, 30 degrees, 70, 120 degree, and 12 degrees are also available, sir.
Okay. So do you you are using 30 degree only? Have you used 0 degree?
So 0 degree and 12 degrees, they can be used for urethroscopy, sir.
Have you used them? Have you seen
Uh,
them?
Yes, sir, I have seen it, sir.
What is the color code for 0 degree?
0 is green, sir.
0 is green. And any other 70 or 120, 12 degree, and I haven't seen. And 120 degree, I have also seen. They are obsolete as well. So do you know the color code for the other ones? 70 degree and 120 degree?
70 is yellow color, sir.
Okay.
And 120 is, I think, white color, sir.
Okay, you need to mug them up. You mug them up before the exam, and the commonly which you use is 30 degree, which you are most probably going to get in exam. Which is on the major institutes, all the institutes that are available. So you will most probably will get the 30 degree. So can you describe how the image, what is the optics, which is there in this rod lens system? How the image is formed?
So it is a Hopkins rod lens system, sir.
Okay.
There will be concave lenses and separated by air.
Okay.
So
there are
images.
lenses, or why is it known as rod lens? The glass rods.
Glass rods, sir. Yes, sir.
Which are concave, and they are separated by air columns.
Air columns.
So the interface between the air column and the rod lens, this acts as a lens. This acts as a reflecting mechanism. So for transmission of image, there is a rod lens system. And however, we need to transmit the light from the light source into the bladder. For that, what is the how is the light transmitted?
Sir, light is transmitted from the around that rod lens system. There is a channel for the light, sir.
So what, there are there is separate channel rod lens system for the transmission of light?
No, sir. On top of that rod lens system, there is a light fiber, sir, that will carry the light.
Basically, fiber optic bundles are there, which transmit light from the light pillar to the vesicle end of the cystoscope. Okay.
Yes, sir.
So you said this is Hopkins type. So what was the original conventional type? How was the image transmitted in the original type, conventional type of cystoscopes?
Sir, there. So I'm not sure, sir.
Actually, conventional type, there were lenses. There were lenses which were separated by columns of air.
Yes, sir.
So in a rod lens system, the majority of the part is occupied by the rod lenses, rods of glass, which are grounded and polished, and there is quite less amount of air columns in between.
Yes,
sir. The difference. So what difference did it make? What difference did it make over a conventional one?
So Hopkins system has a better light transmission, sir, and also viewing angle is better, illumination is better.
Okay. And there was further development. Like there is something like Hopkins 2, which we are currently using. That is Hopkins 2.
Yes, sir.
Yeah. So what is the difference between Hopkins 1 and Hopkins 2?
So it is further the visualization field of view is more than Hopkins
than.
1, sir.
Yeah.
Yes, sir.
They,
And
then,
the lenses are also bigger here, sir.
yeah, the rods are linear and the air columns are much less as compared to the
Smaller.
power wall. So the image is better, brighter, and besides this, the type 2 is autoclavable. Okay. So
Yes, sir.
how do you sterilize this telescope?
So we autoclave, sir, or we use glyceraldehyde, sir.
Glyceraldehyde, Sidex.
Sidex, sir.
Is Sidex method of sterilization?
It is more of disinfection, sir.
It's more of a disinfection. So what is the length of this telescope?
I don't remember, sir, the length.
So it is 30 centimeters.
30
Yeah, 30 centimeter.
Right. 30 centimeters. So what are the various, like we have 0 degree, we have 30 degree, we have 70 degree, 120 degree. What are the various uses for all this? Why do we have such so many varieties of lenses? What is the
So
use?
0 and 12 degrees for
Okay, 0 and 12 degrees for
urethra, sir.
okay.
30 degree is most commonly used, and 70 and 120 degree is to visualize the bladder neck and the anterior bladder wall.
Okay, actually 0 degree is straightforward looking telescope. Okay, so it looks straight. It is used for urethroscopy, and it is usually using, if it is available, then it is better to use a 0 degree for VIU or OIU. Okay, 30 degree
Yes,
is the
sir.
most commonly used. It is a forward oblique telescope. It is known as forward oblique telescope.
Yes, sir.
This is used to visualize the base of the bladder and the anterolateral part of the bladder. Is better visualized with certainly using for cystoscopy and PRP. Then there is 70 degree, that is lateral scopes. 70 degree scopes are usually used for visualization of the bladder dome. And then there is retrospective telescope, which is 120 degree. This is used to visualize the area around the bladder neck, area on the bladder neck and the post prostatic pouch, which can be visualized with the 120 degree.
Yes,
Ashutosh Kumar Tiwari, is he there?
Yes, sir.
Are you there?
Yes, sir. Yes, sir.
Ashutosh Kumar Tiwari? Yeah.
Yes,
Can you
sir.
identify this instrument? What is this? Yeah,
Sir,
what is
this
the
is a,
show which is shown in okay.
sir, this is a resectoscope seat
Okay,
with,
there are two
with an operator.
images. There are two images. It's an obturator. The lower one is the obturator.
No, sir. Bottom one is the inner seat.
Yeah. And the upper one is?
Upper one is a resectoscope seat with an obturator in situ.
So, what are the types of resectoscope sheet?
So basically, there are two types of resectoscopes: continuous and non-continuous or conventional.
Conventional, continuous flow. It's not continuous. It's continuous flow.
Yes, a continuous flow and conventional.
Conventional. Yes. Then, can you classify continuous flow as well?
Sir, in continuous flow, there are two seats: inner seat and the outer seat.
No,
In the
types. There are two types of continuous flow sheets. There is the rotatable one, and there is a
yes,
non-rotatable.
rotatable, non-rotatable. Yes, sir.
Then what are the parts of this super sheet, which you were telling right now? It is the inner sheet.
So it has an inner seat. It has an outer seat. Outer seat has two inlet, has an inlet and an outlet. Inlet for irrigating and an outlet for removing the or emptying the bladder. Then it has
the position of inlet outlet differs between the non-rotating one and a rotating one. Okay.
Yes, sir.
This is a rotating one. Both the inlet and outlet are present on the outer sheet. But however, in case of non-rotating one, the inlet is there on the inner sheet and the outlet is there on the outer sheet.
Yes, sir.
So, can you tell me how the water flows through the sheet? How it
So
goes
through
into
the
yeah.
so the irrigation, so the TOR set is connected to the inlet, and water flows via the sheath into the bladder, and
Which sheet? Which sheet? Via the outer sheet.
so inner sheath
The
to
inner
the
sheet.
inner sheath,
Yeah, through the inner sheet. It
and
flows
water
into the
comes.
bladder.
It flows
Then
into the. It goes into the bladder. From bladder, the water escapes through the serrations that are made over the outer sheath, and it runs between the inner sheath and the outer sheath, and the water exits.
okay, very good. So how is the this continuous flow sheet different from the conventional sheet?
But in conventional sheets, since it is non-continuous, so basically we need to empty the bladder
There is
many
only
times.
one sheet. How it differs? There is only one sheet. There is no outer sheet.
Yes, sir. So there is
If we remove the outer sheet and we use only the inner sheet for section, then it becomes a conventional type. Okay.
Yes, sir.
So there is only one inlet. The rotatable ones, you cannot use it as a conventional sheet. In the non-rotatable ones, where there is the inlet there on the inner sheet, that can be used as a conventional sheet. Okay. So what are the disadvantages of a conventional sheet that you were telling right now?
So
That you have
basically,
to,
since it does not have an outlet, so we need to empty the bladder many times.
frequently we have to empty the bladder. Yeah.
Yes, sir. Very frequently.
Very frequently we have to enter, so it prolongs the duration of operation.
Yes.
Second, side this, since there is for the blood which is seeping out into the bladder, that is not continuously being washed off. So the vision becomes hampered, vision becomes obscured now and then. And third thing, with a continuous sheath, there is no buildup of high pressure within the bladder. With the non-continuous irrigation, non-continuous flow sheet, there might be buildup of high pressure within the bladder. So there might be more ingress of fluid into the system. So if like you're doing it and you're not frequently emptying the bladder, then too much fluid might enter the body and might lead to UR syndrome. And secondly, if there is too much of fluid within the bladder, then during URBT, the bladder wall thins out and there are more chances of perforation if we are using a conventional sheet. So these things were overcome with the development of continuous sheet. Okay. So these are the two sheets. Can you see them? Hello?
Yes, sir.
Dr. Ashutosh. So which one is continuous and which one is rotatable, which is non-rotatable?
Smith's
The upper one.
So the bottom one is rotatable.
Yeah, bottom one is rotatable because both the inlet and outlet present over the outer sheet. And in the upper one, the inlet, the inlet and outer present on the inner and outer sheet. There is a color coding for what are the different sizes in which the receptorship sheets are available.
Yes, sir.
Yeah.
So basically 22 and 24 French are yellow colored, whereas 27 and 28 French are brown color.
It's a black color. Black color. Besides this, now 22 French sheets are also available for narrow urethras. That is color coded white. So can you tell me the formation of a receptoscope? The different parts, all the parts which are required for the receptoscope.
So it will consist of an inner sheath, outer sheath.
You can say a receptoscope sheath.
Working element.
Yeah.
Inner sheath, outer sheath, working element, telescope, and the light pillar and the camera.
Okay.
Along with the irrigation fluids, obviously.
Along with the
irrigation fluids, TOR set connected over the inlet.
Okay. That is the formation of the receptoscope. What are these? What are these we have seen in this image?
So these are the obturators, various types of obturators.
Various type of operators for receptoscope sheath. So how is the receptoscope sheath introduced into the urethra? So can you describe them?
So first one is a simple obturator. Second one is a simple metallic obturator. Second one is the angled or Timberlake, which we see, and the third one is a visual obturator.
Okay, so why do we need this Timberlake obturator? What was the advantage of using it over a conventional standard metal obturator?
So it can be used in those cases where middle over the prostate is enlarged. So in order to facilitate the entry of receptoscope into the bladder, we may use this.
Okay. Besides this, any other type of obturator do you know? There's one loose obturator, which has a rubber ring.
It has a rubber band, rubber covering, sir.
Rubber ring, which flattens out the edges of the receptoscope sheet. This is more protected to the urethra. Okay. What are you commonly using in your institute? Which type of obturator?
So we use a visual obturator.
What is the name of visual obturator? What is the name of visual obturator?
First, next visual obturator.
Okay. Dr. Ankit. Hello.
Yes, sir.
Yeah. Dr. Ankit. Can you identify these instruments?
So this is the working element, sir.
Working element of what?
So receptoscope, sir.
Okay. So working element of the receptoscope.
Yes, sir.
So what are the types?
So active and passive, sir. In passive, there is a finger movement, where there is active, there is a thumb movement.
Which one is active and which one is passive in these images?
So lower one is active, upper one is a passive, sir.
So there are specific names for those. Can you tell me those?
Sorry, sir, I don't remember the names.
So the passive one is the Nesbit's one, and the active one is the Rombeker's one, Bromrucker's one, sir.
Then there is a third type also. There is a Reckon-Pinion system, which was the original word described by McCarthy, in which the loop is loaded over a working element, which can be moved to and fro with the help of a Reckon-Pinion, which is there on the vertical end of the on the eyepiece end of the receptoscope. So, which one are you using in this institute?
The passive one, sir.
Passive one. So, what are the advantages of active one?
So active is cutting is usually faster than the passive one, and it's thumb operated, but chances of injury.
No, active one is finger operated, not thumb operated.
Yeah, finger operated, sir.
Yeah.
And passive one is thumb operated, so chances of accidental injuries are less in passive compared to active, sir.
Okay. Besides this, any other advantage of passive one?
Pardon, sir?
Any other advantage of the passive one? The same working element can also be used for VIU. We cannot use the active one for VIU.
Yes,
if we are using the active one, then we'll have to buy a separate passive one for VIU. So can you identify these? Dr. Anand. Dr. Anand?
Sir, these are basically the cutting loops, sir.
Okay.
And so these are basically used with the resectoscope working element for the TUR for the various procedures of bladder tumor and the prostate surgery, sir, TURP and TURBT.
Okay. So are they all of same size, or there are different sizes which are available?
Sir, actually, it depends upon the type of sheath and the size of sheath we are using, sir. So basically, it is 24 and 27 French are normally available, sir. And yellow is, which is shown here, is a 24 French, sir. And there is also a brown, which is 27 French.
Okay. So what is the material with which the loops are made?
So it is made up of tungsten, sir.
So, can you tell me the flow of current for monopolar TRP? If I'm doing, can you tell me the flow of current, the current loop which is formed?
So for the monopolar TURP, sir, it is going to be having an electric current that actually passes through one of the loops, sir, and thereafter it is actually entering into the non-conducting irrigant fluid, from where it is entering into the tissue body, and thereafter it is actually entering into the indifferent electrode, which is neutral, sir. This is the flow of current which actually happens.
Okay. Okay. So the loops, what is the color coding for loops for bipolar?
So basically it is 24 French for yellow and it is 27 French for the brown, sir.
And for bipolar TRP?
So bipolar, it is blue and yellow. There are
There are two colors.
Two colors are found to be there, sir. Yes.
Yeah, on one label it is blue and on one label it is yellow.
Yes, sir.
Why in this image there are two loops which are shown?
Yes, sir.
So what is the upper loop used for and what is the lower loop used for?
Sir, basically the upper loop is the one that is going to be it is used mainly with the 30-degree telescope, sir, and that is going to be having an curve that is present, which is along with the curve of the 30-degree telescope. Normally it is used for the bladder tumors and for the TURP, sir. And the one that is lower down is actually a straight one, which is used with the 0-degree telescope. Normally it is being used for the resection of the bladder tumor, which is present at the dome, sir. Hello?
Yeah. Hello?
Yes, sir.
Yeah, that's all. And what is this?
So this is actually a Colin's knife, sir.
Okay.
And this is normally used for incision of the bladder neck. It is used for the transurethral incision of the prostate. And sometimes we may also use it for the incision of ureterocele incisions.
Okay.
And while we are doing a nephroureterectomy, the bladder cuffs can actually initially be excised with the help of this.
Yeah, can be marked and excised with the help of.
Yes, sir.
This is also known as hot knife.
Yes, sir.
Because we also have a cold knife.
Okay, sir.
We are not using any energy source. So in this we are using energy source. So it is also known as hot knife.
Okay.
Yeah, what is this?
So
Dr.
this is a
Dipankar.
Toomey syringe. Oh.
Okay, you can also.
So this is a Toomey syringe, sir, which is basically made up of glass, and it is having a metal catheter adapter attached with it with a 50 cc capacity.
This is not a catheter adapter. There is separate.
So it's a metal adapter, sir.
Metal adapter which can be logged onto the
resectoscope sheet, sir. Yes, sir.
There is separate Toomey syringe which has adapter for catheters. You can have that.
Yes, sir.
But this one is having adapter for resectoscope sheet.
The resectoscope sheet.
The resectoscope sheet. Yeah. So what are the uses for this syringe?
Hello.
Where do we use them? Where do you use this syringe?
Sir, this Toomey syringe is basically used for the evacuation of the prostatic chips and sometimes the clots for that is going to be there inside the bladder, sir, for clot evacuation as well.
It is mainly used for clot evacuation. It gives a very good negative suction, so it is very good for evacuation of tenacious clots from within the bladder. It can also be used for evacuation of chips. Normally for evacuation of chips, we are using the bladder chip evacuator, which is there from Boston Scientific. Earlier, Alex evacuator was being used, but right now what we are using is a bladder chip evacuator, which you get from the Boston Scientific. That is it, now.
Yes, sir.
Yeah, Dipankar.
Yes, sir.
Dipankar. Yeah, can you identify this instrument?
Sir, this is a urethrotome, sir. Sex is optical urethrotome.
No, this is not a urethrodome. This is not a urethrodome. It looks like similar. Okay. This is the working element for laser.
Working element, sorry.
Working element for laser. For the use of laser for HOLAP. Okay. There is a channel.
Yes,
there is a channel through which the laser fiber can be passed, and the laser fiber can be fixed onto the desired position with the help of a button which is there near the thumb end of the thumb. This stethoscope. And the part which is protruding beyond the sheath is the guide. The guide which is there over which the laser fiber passes. So this is basically used for laser surgeries. If you are doing a laser HOLAP or if you are doing and block inoculation of bladder tumors. For that, it is used. Okay.
Yes, sir.
So, Dr. Anand, Dr. Anand, Dr. Anand, are you there? Hello? Dr.
Yes, sir.
Dipankar.
Yes, sir.
Yeah, anyone? Can you identify this instrument? These instruments. 1, 2, 3. Number 3. What is the number 3? The lower one. The lower one. What is that? What is that? Hello, Dr. Dipankar.
Sir, can you hear me, sir?
Yeah, I can hear. I can hear you. Yeah, can you tell me what is that? The instrument, the low one, the lowest one, the third one, which is there.
Sir, can I answer, sir?
Yeah, sure.
So this is a optical erythritome. Sorry, this is a sachet optical erythritome, sir.
Yeah. This is optical erythritome. Yeah. And 1 and 2, what are those?
So the second one is actually the cold knife or the sachet knife, and the first one is actually the sheath of the optical erythritome, sir, which is there.
Which is a side channel. Which is a side channel. What is the size of instrument that passes through this?
Sir, it is actually a 21 French sheath.
Yeah.
Which is almost around 20 centimeters, sir.
What is the length? That is 20 centimeters. Yeah. And the SS3 instrument which can be passed through the sheath is 5 French. 5 French. 5 French which can be passed. So the straight knife is sachet knife. Besides this, have you seen other types of knife? Any other type of knife which you've seen?
So there is a half moon knife, sir. Then there is presence of. Hello.
So serrated ones are there.
There is a
serrated ones are there. What is the half moon used for? What is the half moon used for? Half moon.
So BNI, sir.
Okay. What are the advantages of half moon knife? The half moon knife can cut in both to and fro motion, even while proceeding inside. Once you are moving the knife inside, at that time also it can cut. However, the straight knife usually is the cut is made while withdrawing the knife into the sheath. So the half moon can cut both while going inside as well as while coming out. So it is used usually for DNI. Besides that, any other type, the serrated ones which you were telling.
There is a serrated one, sir, which is Ludwig serrated one.
That are used for?
So when there is dense strictures which are there, so it can cut through the dense strictures, which is
like a saw it is there. So serrated knife is also there. So Dr. Ankit. Dr. Ankit, are you there?
Yes, sir.
Yeah. Can you identify this instrument?
So this is a Otis erythritome, sir.
Otis erythritome. Yeah. So what is it used for?
So it is used for dilating urethra, the cutting urethral structure before sir progressing for.
It is used for dilating urethra before.
Before TUR, sir. Before doing the transfer resection of prostate, or we suspect the urethra is narrow, sir.
So it is basically used for calibration of urethra prior to any transfer surgery that you want to say. Yeah.
Yes.
Besides any other use?
So it can be used for cutting of meatus, sir. In the case of meatus stenosis, we can use it for cutting the meat.
In case of meatus stenosis, we can use it for cutting the meatus. Okay, yes. Okay. It is it is basically used to calibrate narrow urethras. Yes, if you want to size narrow urethras, you can use that. So what is in the folded position? What is the size of this instrument?
Size of processor 22 centimeters.
20. So what is the width? How much French? How much French it is?
We can extend it up to, sir, 26.
So what is in the closed position? This is the open thing which is shown there. In the closed position, once the knob is there, then what is the minimum size which is there of this instrument?
So minimum size
14
is
French.
14 French, sir.
It's 14 French.
So actually, the minimum urethra diameter should be 16 to admit this instrument.
Yeah, the instrument size is 14 French, so you can pass it to a urethra which is at least 16 French. And the maximum size till which it can dilate is
31 French.
45.
So 45 French.
45 French. You were telling earlier. Okay. Besides that, it can also be used for female urethral stenosis. Dr. Ashutosh. Dr. Ashutosh Tiwari, are you there?
Yes, sir.
Yeah. Can you identify this instrument?
So this is a stone punch, Mormon stone punch.
Mormon stone punch. Okay. What is it used for?
So it is used for PUCLT. For
PUCLT.
Yes, sir.
Full form PUCLT?
So per urethral systolic
Not TRIPSY.
No, sir.
Why not? What is TRIPSY?
So TRIPSY is basically the use of energy source. We don't use energy source. We are rather using the mechanical force to press the stone. So it is tricky.
And what is systolithopexy?
Sir, in Lapexy, there is intact removal of the stone, sir.
So can you tell me the parts? Have you seen this instrument? Have you used this?
Yes, sir.
Can you tell me the parts of the instrument?
So it consists of a seat or working element. And so we use 0-degree telescope. Here I can see a 30-degree scope.
Yeah, 30 degrees. It's better used with the 0 degree. It's
Yes,
better
sir.
used with the 0 degree.
Yes, sir.
It can be used with 30 degree. Because majority of the people right now have a 30 degree scope. Nobody is buying a 0 degree scope right now. So people use it with 30 degree as well. But it is better used with a 0 degree.
0-degree scope, sir.
So the parts are a sheath and a working element.
Sheath, working element, and the scope, sir.
And the scope. So how will you introduce the sheath? How will you introduce the sheath into the bladder?
So we can directly introduce it
Directly.
while closing the we have to ensure that we close the punch, sir. We don't have to.
There is a specific visual obturator for introduction of the sheath. Okay.
So we can use with that also, and we can use directly also, sir.
Directly to be traumatic. The edges are sharp, so it's not advisable to use this directly. What is the size? What is the size? The size of the sheet?
25 French.
25. As this the distal end, the vesical end is blunt, straight. So it is difficult to introduce the sheath directly, particularly across the sphincter. Okay, so it's better to use a visual obturator along with this. So the eyepiece end of this instrument, there is a knob. What is that knob for? Here, there is a knob. Can you see that?
So for controlling the egress of the fluid, sir.
With this, you can control the flow of fluid.
Yes, sir.
If it is up, then the flow will go inside, and if it is down, the flow will come out.
Yes, sir.
So, what precautions do you take while breaking the stone with this instrument?
So number one, we'll enter the bladder using a visual obturator. Number two, when we are getting a hold of the stone, we have to ensure that we don't touch the mucosa, the bladder mucosa. We have to
For that, what you do?
So for that, we keep the bladder full. Number one. Number two, we lift the vesicle end of the scope after we have got hold of the stone, and then
slightly rotate the scope.
Yes, sir. Away from the mucosa.
And
then we crush it, sir.
Yes, sir. So any other types of any other mechanisms for cystolithotripsy do you know of?
So any other? Beg your pardon, sir.
Any other cystolithotripsy instrument? Look, okay. Can you tell me what this is?
So this is a Hendrickson, I guess.
Hendrickson's
lithotrite.
Lithotrite. Yeah, right.
Yes, sir.
Yeah. What scope? You said that was better used with the 0-degree scope, the Murmaya stone punch. What scope to be used with this instrument? Have you seen this instrument?
No, sir, not used.
Okay. So this instrument is basically used with the 70-degree scope. Okay. Better use the 70-degree scope. And how is this instrument introduced into the bladder? Okay, for introduction of this Henderson's lithotrip, it is brought into the closed position. It is introduced into the bladder. The way it is a blind introduction. Okay, the way you introduce the dilators, the urethral bridges, the way you introduce, in the same manner, this instrument is introduced into the bladder. So it is a blind introduction. So there are chances of injury to the urethra. So that's why this instrument is not used nowadays, and you haven't seen it because there are more chances of injury to the urethra with this instrument. However, it is very sturdy and it is can break hard stones as well. Then Ashutosh, what is this? What instrument is this? Ashutosh, are you there?
Yes, sir. Yes, sir.
Yeah. Yeah. What is this? What instrument is this?
Stone crushing forceps.
Stone crushing forceps. Yeah. Very good. Then what sheath? What sheath it is to be used with?
25 inch. The same seat, sir. 25 inch.
This is only the stone crushing forceps. It is, huh? With how, what do you?
So with the same cystoscope seat, sir.
Cystoscope. Which size? Which size? That is what I'm asking.
So 25 French.
25 French cystoscope sheet. And the lens which you use is telescope. Telescope which you use is
30 degrees. 30 degrees.
30 degrees. So what are disadvantages of this stone crushing forceps? It can break only stones which can come within this jaw, within these jaws, only those stones. So can deal only with small size stones. Plus, it is not all that sturdy. It's not all that sturdy and tough. So if like a hard stone is there, you are pressing too much, you might damage the instrument. So it's not very much used now. Dr. Anand. Dr. Anand, are you?
Yes, sir. Yes, yes, sir. I'm there.
Can you tell me what is this? Very commonly seen.
So this is a Lister's metallic bougie, sir.
Why do you say this is Lister's?
Sir, because it is having a rounded handle, sir, which is there, and there is a tip which is olive pointed. So it is a Lister's metallic bougie.
What are they used for?
So they are basically used for the dilatation purpose, sir. Dilatation of the urethra in patients who are having urethral stricture, or it is before the introduction of a cystoscope, we can use for dilating it, sir. And sometimes, sir, before the introduction, resectoscope actually, sir. And sometimes in patients, when we are doing the progressive perineal urethroplasty, sir, for the identification of urethra also, we are able to using it, sir.
It is basically used for calibration of the urethra.
Yes, sir.
It is used during surgeries as well. Okay. What did you say? What is that? The full name of the instrument?
So this is a Lister's metallic bougie.
This is metallic bougie. What does bougie mean?
So bougie is actually a means. So it is a solid cylindrical. So exactly, I don't
Bougie
know.
means candle. Bougie means candle.
Ha, cylinder.
Candle. Actually, earlier they were made of wax. Okay.
Okay.
So, Buji actually means candle. What is this?
So
What
this
type
is
of
the
dielectric?
Clatton's metallic, sir. Clatton's metallic buji, sir.
Clatton's metallic buji. It's used for the same purpose like
Yes,
Lister's
sir.
metallic.
It is having a
The
violin
difference-
shape handle.
Violin shape handle, and the tip.
So the tip
This-
is a blunt tip, sir.
Smooth tip. It's
Smooth and
not
a blunt
olive, not olive shaped tip like Lister's. So how do you know the size of the this buji?
Sir, it is actually having two sizes written on the handle, sir, which is numerator and a denominator. So normally the denominator is denoting the circumference that is at the base, and the numerator is one which is going to be the circumference in millimeters that is present at the tip, sir.
And these should be used serially. You should start with the
Yes, sir.
narrower one and then proceed
Narrow one to the higher size one.
Now, this is very important. Dr. Dipankar. Dr. Dipankar.
Yes, sir.
Yeah, can you tell me what are
So this is a latex two-way Foley catheter, sir.
latex two-way? It is
Foley
latex.
catheter, self-retaining. Sir?
It is latex. Latex or something else. Siliconized latex.
Siliconized latex, yes, sir.
So you can say it is a Foley's catheter, self-retaining two-way Foley's catheter. So, what is the minimum size of Foley's catheter that you see?
So 8 French I have seen, sir.
Maximum?
24, sir.
So, how do you know the size? How do you come to the size of this Foley's catheter?
So it is written over the Foley catheter and it is also color coded, sir.
So, what is the color code for? What are these? Well, there are two color codes. You can see these. So, the orange one is?
So red one is the upper one is
orange and green.
Yes, sir. Orange is 16, green is 14, sir.
Okay. And the other commonly uses 22 French.
22 French.
Yeah. So
yes, sir. We use it after TUR. Yes, sir.
Yeah. So what is the color code for that?
That is purple, sir.
Yeah. So at least you should know these three color code for these three Foley's catheter. 14, 16 are commonly two-way are commonly used, and you also use the
22.
22. So can you tell me? Can you classify types of catheter?
So we can classify it as non-retaining, non-indwelling, or self-indwelling catheters, or also we can classify it according to the number of channels it has, sir. Single, double, and three-way.
Single channel, okay, double,
single.
Okay. Basically, there are two types. There are two types. They are non-self-retaining or they are self-retaining.
Yes, sir.
Okay. So, can you give me an example of non-self-retaining type?
So, Nelaton's catheter, red rubber catheter.
Okay. And the examples of self-retaining type?
Commonly, we use a Foley catheter. Then pigtail catheters are also self-retaining. Maliko's catheter.
So, it can be self-retaining or non-self-retaining. So, where do you use this catheter, Foley's catheter?
So Foley catheter can be used for diagnostic and therapeutic purposes, sir.
Okay, diagnostic use.
Diagnostic we use in patients where we have to take a sample of urine for urine analysis or culture. Yes, sir.
You will use a Foley's catheter.
Not always, sir. Suppose no, sir.
It's
a non-self-retaining will use.
Basically, prolonged drainage of urinary bladder. That is the most common use. You can also use it for other uses.
Yes, sir.
What other uses have you seen?
The measurement of urine output. post-operative
That
cases
is
after
basically prolonged. If you want to train the bladder for prolonged periods, then
Yes,
you
sir.
can do. If for measurement of urine output, you can also measure it. Why can't you measure it? You can measure it with the condom catheter, where you use a indwelling catheter. You will introduce infection into the bladder just for measurement of urine output.
Yes, sir.
Otherwise, you can ask the patient to collect. You can measure the urine output. If the patient is unconscious, you can use the condom catheter. So why would a fully catheter be required for that? So any other use?
So after urethral surgeries,
Okay, again that is for the range of bladder. You can also the small size only used for PCN, range of PCN. You usually do it pigtail catheter, but if it is like long PCNs are there, then you change it with 8 French or 10 French fully catheter. Would you do this? Percutaneous nephrostomy.
yes, sir.
For percutaneous nephrostomy, do you use this fully catheter? You
Yes, sir.
usually
For
do the
tamponade, we can use, sir.
not for temporary. Like if it is a permanent long dwelling, but if the PCN is there, then you initially do the PCN with a pigtail catheter, and then you change it
Yes,
with
sir.
every time you introduce a pigtail catheter. No,
No, sir.
then you change it with Fullis catheter. There are 8 or 10 French Fullis catheter. So can you tell me there are certain catheter tips catheters
Hello.
The catheter which are there. So what is there are images of catheter tips in this. Hello?
Yes, sir.
In this
Yes,
image?
sir.
Yeah, yeah. So what type of catheter is that?
So it's a straight tip catheter, sir.
That will be an lateral catheter. It is a single
Yeah.
hole straight tip catheter. That will be an lateral catheter. The
Yes, sir.
B will be
I'm not sure, sir.
lateral catheter. What is this used for? Lateral catheter.
Collection of urine, sir. Urine sample.
Yeah, urine sample if required. Lateral catheter is better than using a Fullis catheter. It's a bit more sturdier than Fullis catheter. And
yes,
secondly, it is a single use. It's cheaper as compared to Fullis catheter. You can use a lateral catheter collection of sample. Then most commonly what you are using is for self-calibration. Don't you advise self-calibration with this?
Yes, sir.
The self-calibration of urethra. If patient is doing usually an lateral catheter is they are doing with an entrance catheter. Is whistle tip catheter. So there is a whistle tip. So it helps in evacuation of clot. Evacuation of clot is there. There is a bigger eye, so clots can be easily removed from the bladder. The C, what is C? C type.
Coded tips, sir.
Yeah, coded tip. Where are they used?
In difficult catheterization, big prostates.
What is the benefit of this?
Sir, I'm not able to understand you, sir. Its voice is breaking up, sir.
Big prostate and difficult catheterization. Voice is breaking up. This is cow tip catheter. Okay.
Yes, sir.
This is used for big prostates. And D?
Malaport, sir.
Yeah, the D is Malaport. And E?
I'm not sure, sir.
E is Pizzers. The Pizzers catheter. Pizzers. Okay. And F is Fullis catheter. Which we are using. Okay. So can you tell me, Dipankar, can you tell me what is this? What is this? Can you identify this instrument?
Is it a Haygroove bougie, sir? Metal bougie?
Is it a Haygroove metal bougie? Or something better you can describe?
I'm not sure, sir.
The Haygroove staff. It's not a bougie. Haygroove staff, which is right. And what are the uses of Haygroove staff?
So it is used to used in urethroplasty, sir. Posterior
Yes, very good.
progressive posterior urethroplasty.
Very good.
Uh,
Yeah. What is it used for?
So we to locate the proximal end of the urethra so that we can cut through to it, sir.
That locate the distal most end of the proximal
posterior
half
proximal
of
end
the
of the urethra.
So you should gently pass it through the SPC tract into the bladder and then through the bladder neck into the urethra. And gently you should push and try to feel the this
tip of
this agu stuff, so you can locate where you can find the urethra. Okay.
Yes.
Thank you very much. I suppose the majority of the important lower tract instruments have been covered. Now I'll hand over to Demalyo. Hello, Demalyo.
Thank you,
Yeah,
thank
yeah.
you, thank you, Pramukta. So this was a very elaborate description of almost all lower tract instruments. What I noted here for the students that you are very keen on telling the sizes of the instruments by seeing what is written on the instrument's body, but examiners would like to always answer these as in the form of a color code. Remember this. The next thing is that when very senior examiners come, they will test the water with couple of questions only. So these will not be, there will not be straightforward questions as written in your textbooks. They will test the water and they will know whether you have used these instruments and use this in OT or not. Like in your working element and in your resectoscope, they can ask you questions like if you have lost the markings, the engravings on the inflow and outflow channels, how do you know that which one is inflow and how do you know that which one is outflow in a continuous resectoscope? So go through those things. There are other questions like in a Mormar bladder punch, bladder stone punch. Some student could not answer that there should be an obturator along with it. It is always best to use a visual obturator, but there is a specific problem if you do not use it without a visual obturator. There is always, when you close it, there is always a bubble of air inside the inner channel when you introduce it in a male urethra vertically. So remember those things and know how to remove that when you actually open the outflow, that that air bubble goes out. So these are the questions that examiners tend to ask. You can only answer these things if you have used the instrument and or you have seen using those instruments. The other question is that in Pramukta's presentation, there was a similar distal tip of a Foley catheter and a Nielsen's catheter. So Dipankar should have told that although that was not a tip perforation, but the Foley catheter is an self-retaining catheter. That is why it has a balloon, and the Nielsen's catheter does not have. The other question that may arise that if you encounter a stuck catheter in a patient, how do you remove those? These are pertaining questions that examiners will tend to ask, and you cannot answer those things if you have not used it. So without wasting any more time, let us go to the upper tract instruments. Dr. Raj, are you with us? Dr.
Yeah,
Raj,
yeah.
please unmute yourself.
Yeah.
So I hand over this mic to Dr. Raj to continue with the upper tract instruments.
Am I audible?
Yes, you are.
And my screen is
yes, your screen is visible.
Okay. Okay, so I'm going to discuss upper tract instrument. Upper tract basically consists of PCNL instrument as well as ureteroscopic instrument. So to start with, without wasting your time, the first important picture is shown here. So what is it? Can anyone tell?
So this is the initial puncture needle, sir.
Yeah, PCN puncture needle. Okay.
Yes.
So it's here you can see the color is pink.
Yes, sir.
So can you tell me the size of this puncture needle?
This is the most commonly used and it is 18 gauge, sir.
Yeah, correct. 18 gauge. And do you know there are two types of tips? Tip
So
of this
there
needle.
is one is going to be a diamond tip, sir, and the other is the bevel tip, sir.
Yeah, this one is diamond tip, and this
Yes,
one
sir.
is bevel tip.
Bevel tip.
So what is the difference, and what are the advantage of making these two type of tip? Do you know?
So bevel tip actually is the one which may sometimes slip out of the PCS system, sir. And there is the needle also tends to be bending towards the bevel, sir. So
Yeah.
so sometimes the diamond tip is advantageous because it is straight on entering into the PCS system, sir.
Right. And you can see in this photograph, when you puncture with this diamond tip needle, you are going straight because this is the sharp edge which cause cutting of the fascia and muscles. So you go straight. In bevel tip, this end is a sharp edge. Okay.
Yes,
so
sir.
there is a slight movement away from the midline when you puncture. So this is the difference when you do puncture. Another major disadvantage with this bevel type of needle is that when you use guide wire during the puncture, so when you manipulate the guide wire, suppose you push and sometimes you withdraw, so there is a chance of damage of the guide wire coating.
Yes.
Have you come across?
Yes, sir. The coating gets disrupted,
Damage.
sir.
Yeah,
Damaged,
it's
yes.
stripped off. So
Yes,
the
yes.
beveled end is more or less we are not using in the puncture.
Nowadays.
Yeah, so the diamond tip is best for the puncture. Okay. So what are these two types of puncture needle? You can see here. This is.
So this is actually a 3-part needle, sir, which is
3-part puncture needle. Yes.
Yes, sir.
And
So
this is 2-part puncture needle.
and this is a 2-part puncture needle, sir.
Yeah. Can you tell me the advantages of 3-part puncture needle when it was initially developed? Or
So 3-part puncture needle is actually having a inner sheath, outer sheath, and thereafter an obturator. So
Yeah.
the since the inner sheath is there, it is very narrow. It is almost around 21 gauge. So we can make multiple punctures, sir, without injuring much of the renal parenchyma. So in initial parts of the practice, we can use this so that we can cause minimum injury to the renal structures.
So in your institute, whether you are using 2-part or 3-part?
So we are using 2 parts, sir.
2 parts. So see, there are this outer part. This is smaller. Okay.
Yes, sir.
This is inner part and this is obturator. Okay.
Obturators.
So the inner part is longer as compared to inner part. Outer part.
Yes.
So the idea of this 3-part puncture needle is that while doing puncture, you keep outside the renal parenchyma or renal capsule, this outer part. Okay. Outer sheath is of larger diameter. So keep outside the renal capsule. And then we enter these 2 parts inside the pelvic ileal system because it has less diameter. And theoretically, it is causing less injury to the renal parenchyma and thus less chance of bleeding is there. But it is basically a theoretically answer. Okay. Practically, it has been seen that there is no much difference between these 2 part and 3-part. Okay.
Yes, sir.
So there is also color coding in this initial puncture needle. 3 types of color coding. 18 French is pink one, yellow is 20, and 21 is black.
Black.
Okay. So what is this?
This is actually a Chiva needle, sir.
Yeah, Chiva needle. Some examiner may ask you, where is Chiva? It is in Japan. Okay. So it was designed at the University of Chiba, Japan. And this beveled end is there. Can you tell me the use of this Chiba needle nowadays?
Sir, we have also used in the other than the PCNL, we have
Yeah,
sometimes
yeah.
used
Other
it for
than-
the, we have used in the periprostatic blocks, sir. We have used it as.
Okay. And you can also use in liver abscess drainage. Okay. And one great advantage of this beveled end is that when you do ultrasound guided puncture, this beveled end is more ecogenic and it is better seen as compared to diamond tip needle. So for ultrasound guided puncture, if you are doing, the beveled end needle is better as compared to diamond tip. Okay.
Okay, sir.
So regarding guide wires, can you tell me the sizes of guide wires? What
guide
you are
wires are
using in
actually-
your OT?
So normally the most common guide wires that we are using is going to is 0.032 and 0.035.
What?
But it ranges from 0.
What 35 what?
Sir,
Centimeter?
it is mm.
No.
Sorry.
It's important. Examiner may
Inches.
ask you. What is?
So it is
0.0?
inches. It is inches. It is inches, sir.
Very good. It's
Yes.
inches. Okay. So always tell complete. 0.035 inches. Okay. And lengths are usually 150 centimeter. Okay. So the commonly used that we are using in our OT is 0.032 or 0.035. For the pediatric cases, for the small diameter, this DJ stent, we are using smaller also.
0.018 or 0.025, sir.
Yeah, correct. The length is around 150 centimeter. Okay. Can you tell the length of floppy tip?
So floppy tips actually is around 5 centimeters. But sometimes in certain guide wires, it is also 8 to 8 centimeters as well, sir.
Generally, it's 3 centimeter to 7 centimeter. Okay. So depending upon the tip of this guide wire, they are again classified into straight tip, J tip, angle tipped. Can you tell the use of this angle tipped guide wire?
Sir, angle tip is sometimes when there is when we are not able to cannulate the or locate the ureteral orifice, sir. In that situations, particularly when there is a large median lobe of the prostate.
Very good.
Then in that situation, sir, we are able to negotiate this angle tip and ultimately locate the ureteric orifices, sir.
Yeah, in these type of cases where there is a median lobe hypertrophy due to large prostate, the ureteric orifice is sometimes difficult to locate. So this type of angle tip guide wire is best suited for eccentrically placed ureteric orifices. What about J tip? Can you tell the advantage of this J tip?
So J-tip is something which is very much suited for as an initial guide wire we put in the PCNL or during the PCN as well, because it will be causing less amount of trauma to the PCS system, because it is the J-tip, sir, it is the U portion that is attaching to the that is hitting the PCS system, so it will not perforate the system, sir.
Exactly, exactly. The leading edge is this elbow, not the
Yes,
tip.
sir.
So it will not cause injury to the mucosa. So false passage is less. So the J tip is causing less injury to the pelvic LSN system during this guide wire passage. Also, if you have impacted stones in the ureter and you are doing ureteroscopy, so because there is a edema due to mucosa around the stone, so straight tip may enter into the submucosal plane and it may not enter the ureter properly. So in these type of cases also you can use J-tip guide wire.
Okay.
So there are another two type of guide wire, Benston type guide wire, which have 8 to 15 centimeter floppy tip. This extra length of floppy tip allow the operator to place multiple curls of wire up in the renal pelvis. This makes it's a good safety wire because it gets coiled in the upper track. The another one is Lunderquist guide wire, which is again extremely stiff, and it is made up of stainless steel. It has a flexible tip. So regarding coating of the guide wire, can you tell this black material is what?
Sir, actually it has a nitinol core, sir.
Yeah.
And that nitinol core is being covered upon thereafter by the polyurethane material.
Yes.
And at the tip, sir, it is for the hydrophilic guide wires. At the tip, we are using tungsten, which will be adding the radio opacity to it.
Yeah.
And also there is a hydrophilic coating that is going to be over the polyurethane material, sir.
Okay. So what does this hydrophilic coating do? Why
So
it
it
is
actually making it is actually causing the water to stick, sir. So ultimately what happens is the guide wire becomes very much smooth and slippery. So there will be an easy passage and easy passage of the guide wire.
hydrophilic? Hydro means water, philic is means love. So these hydrophilic coating absorb water and become slippery. Okay. So now coming to dilators. While doing this PCNL, there are 4 types of dilators which we are using. Progressive facile dilator, malleable dilators, which are also known as Amplaz dilator, metal coaxial dilator, that is also known as Alkens dilator, and then high pressure balloon dilators. Okay. So these are initial facile dilator. Okay. Can you tell the material?
Sir, it is made up of PTFE, sir, polytetrafluoroethylene.
Yeah, PTFE. So it starts from 6 French in size. Okay. Can you tell me the advantage of using this PTFE facile dilator? What are the advantages?
Sir, it actually is used for the track dilatation, sir, mainly for after the puncture and placement of the guide wire. We are using it for the track dilatation during the PCNL, sir. So it is going to be used as a serial dilator up to the desired track that we want, and thereafter we are placing the amplage sheet thereafter.
Yeah. For the initial dilatation, we are using this facile dilator. Why? Because this PTFE is very stiff material. Okay. So the chances of bending is very less in this type of dilators. So initially, if you dilate, for example, in case of previously operated cases, when there is a large fibrosis in the retroperitoneal or perirenal space, this type of dilators works very good. Okay. So for the initial purpose of dilatation, we are using up to 6, 8 French or 10 French. Then we do regular either with Alkene dilators, or you can use Amplaz dilators. Okay. Can you tell me the disadvantages of this?
The disadvantage is every time we are taking it out, sir, then it will ultimately cause the increase in the chance of bleeding, because the tamponade effect of that particular tract is being lost. So it will have more amount of bleeding, sir.
Yeah, you are right. But these are more with Amplaz dilators, where you are using large diameter of that dilators. Okay. The main disadvantage while using initial 6 or 8 French dilator is that when you force, there may be a chance of kinking of the guide wire. Okay.
Kinking of the wire. Okay.
Yeah, guide wire kinking is more with this initial type of facile dilator. So coming to malleable dilators, these are Amplaz dilators. Okay. So the sizes, can you tell me the sizes?
So normally it is the whole cook set which is being supplied. That is along with the 12 to 30 French is what we are supplied with, and it has 24, 26, 28, and 30. These are dilators which are supplied with the amplage sheath along.
Amplage sheath. Yeah.
And there is a Cobra catheter which is also supplied with it, sir.
Okay. And these 3 are?
So these 3 are the initial fascial dilators that we were using. Like,
what is the use of this Cobra dilator?
So the Cobra dilators, sometimes we are going to be using it after the placement of the guide wire. We can place the Cobra catheter, and over that we are dilating the amplage dilators, sir.
Yeah, the idea is to put the Cobra catheter over the guide wire up to the upper ureter so that it gives stability of the track. Okay.
Yes, sir.
So during dilatation, what is the movement of your hand? Can you tell me how to dilate?
So it's a screwing movement that.
There are two types of movements during dilatation. Tell me.
So the one is the screwing movement that we do, sir.
Yeah.
And the other is pushing forward.
Yeah, right. You are right. Forward movement and screwing movement. So
I don't
when
know,
you
sir.
rotate, so which in which direction you are rotating? Clockwise, anti-clockwise, or something
It's
like that?
clockwise direction, sir.
Why? If you do anti-clockwise, it will not dilate the track.
So it might be leading to the kinking of the guide wire, sir.
No, no. The idea of dilatation is to first you push forward and do half clockwise rotation, half anti-clockwise direction, so that it will spread the tissue in a circular fashion. Okay. Half clockwise, anti-clockwise. So the tissue will be displaced circularly.
Right, sir.
Okay. So main disadvantage that you was telling that tell me
So
the
bleeding
disadvantage.
So that was again, this is also causing bleeding because each time we are taking it out, sir.
Yeah.
And sir, kinking can also take place in this.
Pardon?
But to a lesser extent, if you are using the Cobra catheter, then the kinking becomes less.
Yeah, yeah. That's the use of Cobra catheter. It gives stability. Okay.
Yes. Yes.
And the disadvantage is that every time you have to dilate, if you use bigger dilator, then you have to remove the initial smaller dilator, and that causes bleeding because tamponade effect is lost. Okay, so this is the major disadvantage of this M+ dilator. The third one is alkane metal coaxial dilator. Okay, so can you tell me the what is this?
So this is a central rod, sir, with an olive pointed end, sir.
Guide rod.
Guide rod.
Yeah. What is this?
So this is the rounded knob which is present in the distal end of the guide rod, sir.
What is the use of this knob?
Sir, it will not allow the further dilators to go beyond the guide rod, sir, so that it will not be it will not help in it will prevent in perforating the PCS system, basically.
Okay. So the initially, suppose you are introducing this 6 French first dilator. Okay, it will get stuck here. Okay.
Yes, sir.
The second 9 French. Oh, it will get stopped here. This knob is small. If you are using this bigger one, this knob will not prevent this bigger dilator.
So, but the design of alkane dilators are such that it will snugly fit one another, sir. So
Yeah.
they will not go.
Yeah, yeah, snugly fit. But what prevent this bigger dilator to overshoot? Anyone? Okay. So when you will see the back of these dilators, you will find one ring that is folded inward. Okay. Hello.
Yes, sir. We can hear.
On the back of this this distal part of the dilators, you will see it is inward folded and making a ring. Okay, that ring prevent get stuck in the previous one. Okay, it will not allow to move forward. Okay, just go in your OT, then see it clearly. Okay.
Yes, sir.
So what are the advantages of this alkane metal coaxial dilator? These are also known as telescopic dilator.
Yes, sir.
Because it is like a telescope. Okay. So what are the advantages of these alkane dilators?
So there are two advantages, sir. First of all, since we are it is basically serial dilators which are one upon the other.
No,
So
no,
we are
no.
not taking
These
that.
are not serial dilators. Serial dilators and telescopic dilators are different. Okay.
Okay.
Serial dilators were M+ dilator.
Yes,
These are
means we are not taking it out. So these are coaxial. They are basically we are not taking it out every time, so the chance of bleeding becomes less. First, second, they are able to be used in dilatations of thicker and fibrous tissues when there is already a history of any surgical procedure which was done in the same site. So that is yes, sir.
Right. And the third advantage is that it is reusable. Okay.
It is reusable.
This is because after certain time, M+ sheath and facile dilators, M+ dilators, where we are using repeatedly, but there is a definite life of the plastic material. Okay. But I am using this alkane dilator for the last 8 years, and still it is working. So these are very good dilators. Particularly if there is a history of previous surgery, previous PCNL or other any retroperitoneal surgery. But one precaution should be taken during this dilator, using this dilator. So in other words, you can tell me the disadvantage of using this metal dilator. What is the disadvantage?
Sir, it can one has to be cautious about that the guide rod is not going forward and it has to be stabilized. Otherwise, it might perforate into the PCS system, sir.
How you will stabilize the guide rod?
So that is with the hand we are normally stabilizing it, sir.
Yeah, you are
Under
using two
fluoroscopic
hands.
guidance.
Yeah, you are
Yes,
using two hands. Okay.
Yes,
just with the help of left hand, if you are a right-handed person, okay, with the left hand, hold this guide rod firmly, and this support this upper hand with your chest, okay, and hold it firmly, and then with the right hand, you give the rotating movement and place other dilators. Okay, so your this guide rod should be held firmly with your left hand, and this left hand is should be close to your chest so that it gives stability to the left hand. Okay, and sometime you can hold this left hand, and with the help of this this image intensifier, you can touch the image intensifier if it is close to your puncture site. Okay, so it will again give you the stability. Okay, so how many these metal tubes are there?
Sir, actually, they are in an increment of 3 French, sir, and that starts from 9 French and that goes up to 24 French, sir.
24 only.
So sometimes there is specialized 27 and 30 also which are available, sir.
Yeah, generally it's a set of that I am using is Stoj one, and it's a set of 7 dilators up to 27 French. Okay.
Okay.
Okay. Now the fourth one is balloon dilators. So what is this balloon dilators? Can you anyone can tell regarding this? The details of this catheter?
So this is actually a balloon dilator which is also used for dilatation, but the point of difference here is that like the other axial dilators, it is a radial dilator, sir. So what happens is that it is going to give a lateral compressive force rather than the shearing force which is coming across. It is giving a lateral compressive force, sir.
Anyone has seen this during OT?
No, sir, just read it.
So here the M+ is backloaded in this type of dilator first. Okay, after putting this guide wire, after doing initial puncture, then we put guide wire, then we backload this guide wire with this one. M+ in already backloaded. Okay, then there is a 2 marker, 1 and 2, that is radio big marker. First marker you keep inside, just inside the this calyx. Okay, then you inflate this balloon. Then this balloon will get inflated and it will cause dilatation. Then you slide this amplage dilator over the tract. Okay.
Yes, sir.
Now regarding amplage sheath. Okay. So this is again made up of this Teflon. Okay. There is two types of end. One is beveled and one is plain. Okay. So can you tell me the advantages of this beveled end?
So beveled end is actually having a better vision, sir. And sir, it is one
Better
thing that
vision,
is so it actually allows the more amount of fluid that passes, so it is having better vision, and sometimes we are able to have a better access to the PCS system. Means that is the thing, sir.
The beveled end, the advantage of this beveled end is that this when you enter inside the pelvic calyceal system, okay, if there is a bleeding from some part of the parenchyma, you rotate this amplage sheath, okay, and put the beveled end over that bleeding area, so it will prevent the bleeding. This is a practical tip. Okay. The second, the beveled end promotes ease of insertion inside the pelvic calyceal system. Okay. But sometime if there is no space in the calyx, suppose calyx is very small or it is a diverticulum loaded with a stone, we can use the opposite end of this amplage sheath. Okay.
Yes, sir.
Okay. So, Acha, what are the advantages of this amplage sheath? Why you are using this amplage sheath? If you don't use this amplage sheath, what will happen?
So the tract will be lost, sir, because it is providing the stability to the PCS system, and every time we have to go in and go out, so it will give us the ease of movement, sir.
Right, right. Any other advantage? It will prevent
it is giving the tamponade effect, sir.
Very good. It is giving tamponade effect. So the bleeding is less, venous oozing is less. So you can do your job comfortably. Any third advantage?
It will decrease the pressure of the internal pelvis.
Right. It is also decreasing the pressure. And it's also prevent the leakage of the fluid in the retroperitoneal space. Okay. So these are the advantages of amplage sheath. So regarding nephroscope, okay, rigid nephroscope, we are using, these are Stogemed nephroscope. What is this called? This type of making. This eyepiece is away from this scope main.
So offset.
Offset, yeah. Offset. There may be one another type like this. What you will call that?
Angle type.
Angle type, very good. Generally, a smaller one, the mini PCNL nephroscope is angle type.
Angle type.
Yeah. So the idea of making this offset, what is the idea behind this?
So
in cystoscope, in the telescopes that is used for during cystoscopy is straight. Okay. Here it is offset. Why?
Sir, so because it first of all gives a better grip to the and thereafter there is we have to insert the instrument and
very good, very good. For the ease of instrument entry, okay, you are using lithotripter here, you are using grasper here, so it should be, the camera should be away from the working channel. Okay. Okay. So the sizes can be different. It ranges from 12 French, 18 French, 20 French, 24 French. Okay. Then nothing more in this nephroscope. These are mini nephroscope. Here you can see the angled one. Okay. The size of this instrument is 12 French in Storge and 14 French in Wolfmed. Okay. And the central channel is around 6.7 French, where you can use instrument up to 5 French. Here, the fiber optic system is used, whereas in standard this rigid nephroscope, the rod lens is being used. So the newer one, the mini nephroscope is better. It has long life as compared to the previous one. Okay. Can you use lithotripter in this type of mini nephroscope? Lithotripsy? Or it's only for this holmium laser?
So
we can use pneumatic also.
Yeah, you can use pneumatic lithotripsy also. So coming to next type of instrument, these are ultra mini PCNL. It was devised by our Indian doctor Janak Desai. So here we are using 1 mm diameter telescope. This is only 3 French. Okay. Then nephroscope is 7.5 French. It gives stability to this delicate telescope. Okay. And the ampler sheath is of 13 French. The final picture is like that. Here we are using this only laser fiber. But nowadays one trilogy lithotripter has been developed. Do you know any trilogy lithotripter? Anyone is knowing regarding trilogy?
Shock pulse.
All the 3 modality this lithotripsy can be done: pneumatic, ultrasound guided, as well as laser. Okay. So in these instruments are still not in market, but work is going on, and they are claiming that they can use this ultrasound probe in this type of ultra mini PCNL.
Pardon me, Dr. Raj.
Yeah.
Dr. Raj.
Yeah.
We are actually way short of time.
Okay.
For the booking time. So
4 or 5 slides are there.
Yes, can we make it concise to let them know what is absolutely necessary in the examination?
Yeah.
Thank you.
Actually, I have given my exam in 2013.
So
and also I am not attached with any medical college.
Super Park and UMP is not necessary right now. Can you please go to the stents and ureteroscope straight away?
Yeah, just only 1 slides are left. Regarding stents, these are important. Okay. So stents, can you tell me the material of stents?
So the stents can be some most polyurethane stents. It can be silicone stents. It can be metallic stents. It can be drug-eluting stents. And it can be sometimes like the C-flex and Percuflex. These are also different varieties that are.
So what are the advantages of this using silicone over polyurethane?
So actually silicone is something which is much more biodegradable, and sir, it is something which is more biocompatible, sir. So we are able to keep it for a longer period of time in the body.
Yeah. Also, the irritability of silicone is less
irritation is less,
to polyurethane.
Irritation is less.
Yeah. In DJ stent, there are side holes. Okay. Can you tell me the purpose of these side holes?
So the side holes, sir, they are actually letting in. Okay, so don't know.
They are allowing this drainage. Hello.
So better drainage.
Yeah, better drainage purpose. These are 2 part. These are called double J.
Double J.
Okay. Due to high memory of this polyurethane, this retain its shape. Okay. What is the
Muscle
advantage
double
of this to double check?
So they will be helping in keeping the stent in place, sir, and that is.
It will
So that
prevent
is
the
one
migration.
migration will not be there. So yes.
Yeah. So can you tell me what is the duration up to which we can keep the DJ stent in case it is made up of polyurethane, if it is made up of silicone and metallic one?
Sir, polyurethanes are something which can be kept up to 3 months, sir. But
3 months.
maximum it can, yes. And silicone stents are somewhat longer duration, so it can be kept for about 6 months, sir. And
It may be kept up to 1 year. Okay.
1 year. And metallic stents are somewhat longest duration.
Right. What is the use of this metallic stent?
So they are basically preventing from the external compression. So this is the most sturdy one, and so they are going to be preventing the external
In
compression.
case of cancer patients, where the ureteries get compressed by the tumor. Okay. Now coming to ureteroscope, these are semi-rigid ureteroscope. Okay. Hello.
Yes, sir.
Semi-rigid ureteroscope. Can you tell me the sizes of ureteroscope that we are commonly using?
So we in our institute are having the Wolf ureteroscope, sir, which is 6 by 7.5 French, sir. And,
what do you mean by the 6 and 7.5 French?
So 6 is actually the basic thickness that is present at the tip, sir, and 7.5 is that is gradually going at the base. The base is basically 7.5 French, sir.
Yeah. What is the advantage of making this tapering of this ureteroscope? Why it is made in such a way that it is tapered?
So that there is an easy entry, sir. There is a narrowed ureter, sir. We will be able to, without injuring much of the ureter, we can enter into this, and with further movement, we can easily go and go for a stepless dilatation of that ureter,
Right,
sir.
right. Very right. So the gradual dilatation of ureter takes place when you use this tapered ureteroscope. Okay. So why it is called semi-rigid? It is made up of a stainless steel, but it is known as semi-rigid. Why?
So the first 5 to 7 centimeters, sir, they are having the ability to bend a bit. That is the thing, sir.
Okay, then whether rod length is used here or this fiber optics in ureteroscope?
Ureteroscope, I think it's fiber optics. I don't know.
Fiber optic. That's why it is called semi-rigid. Okay, so again, advantages of offset design of eyepiece is the same as I have told in nephroscope. Okay. So what is this?
So this is a flexible URS, sir, flexible ureteroscope, sir.
Mm-hmm. So can you tell me what is this part?
So this is basically the lever, sir,
yeah,
which is helping in the deflection, of the tip, sir,
Yeah.
in the upward or the downward direction.
Right. So what are the different types of deflection?
So there are two different deflections, sir. One is the intuitive, and the other is the non-intuitive one, sir. And
that is related to the makers. Okay.
Yes, sir. So that is active deflection is basically the one that we are doing it with the hands, and the passive deflection is when they are just forward movement of the scope, it will hit onto the PCS system wall, and thereafter it will enter into the calyx, sir. So that is the passive deflection.
The active deflection is under control with the help of this lever. Okay. The passive deflection site is few centimeter away from the tip. When you enter, when you are supposed to enter the lower calyx, so this part of this passive deflection part comes in contact with the pelvis of the kidney, and it will help in entering the lower calyx much more easily. Okay. So the active deflection is up to How many degree? Do you know?
It actually depends upon the maker, sir, but normally it is upward is 270 degrees and downward it is also nowadays stores are making it 270 degrees. Earlier the downward deflection was lesser, but now it is 270 volts.
Up to 270 degree it is possible. Okay. And what about passive deflection? Degree of passive deflection? Around 130 degree. Okay. And it's only in one direction, only in downward direction. Okay. Active deflection can be in both the direction, but passive is only on the downward direction. Okay. What is this?
This is a ureteral access sheath, sir.
Access sheath. Okay. So the advantage of this using a ureteric access sheath?
So the two major advantages are, sir, that once we are placing it inside the ureter, there is an easy access to the instruments. We can go in and out very quickly. And the other is basically it is helping in the drainage of the urine. So they will be maintaining the intrapelvic pressure at a lower level. And that will prevent the further sepsis, which has very high chances in RIRS surgeries.
In RCT's various trials, this is the only advantage that is clearly mentioned, that it prevents the sepsis. This is proven. Okay, it will decrease the intrapelvic pressure and thus it decreases the chance of infection. So where do you keep the tip of this ureteric access sheath in the pelvic ileal system?
Sir, just beyond the means actually, so we are keeping it almost around 5-6 centimeters below the PUJ junction.
Below the PUJ, this is important. Why not above the PUJ?
So it might be
movement of scope will be hampered, sir.
Pardon?
Scope movement will not be proper.
Yeah, exactly. It will cause hindrance of the movement and thus scope may break. Okay, so it's always preferable to keep just below the PUJ. Okay, then these are baskets.
Yes, sir.
Okay, can you tell the name of this basket?
This is an N circle.
N circle, very good. And this is?
Yes. So this is engage.
Engage. So the advantage of using this N circle and engage, can you tell me the where you will use this N circle and where this engage?
So actually N circle is not occupying much of the space in calyx. So we are so basically these are for relocating the stones from the lower calyx to the upper calyx.
These are very good for the relocation of the stone. Okay, from lower calyx, if you want to take it to the upper calyx, then N circles are better, and these are for the grasping and for the removing of the stones. Okay, thank you very much to you all.
Thank you,
Dr. Raj. Thank you. Again for the very elaborate presentation. But again, I advise students that you do not only mug up the sizes and the nuances of the instruments, you go through the surgery as well, because examiners tend to go to the surgical part starting from that instrument. And there is a tendency of examiners to ask you to choose one instrument of your choice. This is a very tricky part, where you only, the first thing is you need to avoid that thing. But if he insists, if he or she insists, then take one instrument whose head and tails you know, and the surgery associated with it you must know. So now let us hand over to Dr. Ahsan for laparoscopic instruments. To you, Dr. Ahsan. Hello. Please unmute. Dr. Ahsan, please unmute. Please unmute yourself.
Hello.
Yes, yes. Now you are audible. Now you are audible.
So my topic is for laparoscopic instrument, which I will go relatively short because already much time has been. So laparoscopic is my voice audible?
Your voice is audible and your screen is visible now.
Okay. So they have optical devices, equipment for creating and maintaining domain, instrument for access, operative instruments. Then there are different energy sources, tissue.
Can we have others muted, please? Can we have others muted?
Hello. Hello. Yes.
Yes, please go on. Please go on.
And then miscellaneous. Next slide. So can you identify these instruments? Hello. For students. Hello.
One of the students, please volunteer. One of the students, please volunteer.
So these are the lenses 0 degree and 30 degree which we commonly use for laparoscopy. The 0 degree has a green color code and 30 degree has a red color code. Then there are light sources. So what is this instrument? What is this box? Anybody? Hello? Hello? So this is a light source. Then there is camera. For laparoscopy, camera has evolved from single chip camera to 3 chips camera to high definition camera. So can anybody from the students can tell what is the difference between 1 chip camera and 3 chips camera?
Dr. Ashutosh Tiwari or Dr. Dipankar Sharma? Please volunteer for the answering.
So I will tell they actually 1 chip camera were having blurred images because they were single single chips, but in 3D chips camera there are 3 CCD devices which filter red, blue and green light, so the pixel resolution is more. And while in 1 chips camera images were blurred because of red, blue and green light transmissions were when taken from other pixel unit there were artifacts. So now again with this 3 chips camera your vision is improved and you are better able to perform surgery. And now the high definition camera has come which has got more resolution and width of the pixel. And that has caused more clarifications and more precise viewing of the intra-abdominal organs. So first of things is very important how you get access into the peritoneal cavity with the varus needle, open access, the direct trocar and optical trocar. Can anybody identify this instrument?
So this is a varus needle, sir.
Okay. So what are the parts of varus needle?
So varus needle has a tip. There is a shaft, and there is a hub with a spring system inside, sir.
Yes, sir. What are the color indicators inside it? Red and green.
So
green. Yes. So green,
I don't know, sir.
Okay, green will indicate when you are in the negative milieu, that is in the interperitoneal space, then the green will show. If you are in the preperitoneal space, then red will show. So when in obese patients, will you prefer open technique or varus needle? Okay, varus needle will be safer even in obese patients. So these are the different parts of varus needles, which we have already described. This is open Hassan-Trocar technique. What are the part of Hassan-Trocar? Hello. Hello.
So there is a obturator and there is a outer sheet, sir.
Yes.
The trocar.
Obturator is blunt or sharp?
Blunt, sir.
Yes, definitely. So that's why it is preferable when the patient has undergone previous intra-abdominal surgery. We will find some adhesions intra-abdominally. So the blunt trocar will be helpful. You give 1.5 to 2 centimeter incision, it go under direct vision, so less chances of injury.
Yes, sir.
So what is this instrument shown?
Sir, these are Visi ports, sir. Laparoscopic ports, sir.
Yes, yes, it makes sense. So what are the different parts of trocar?
There can there will be an obturator, and the outside trocar will be there. There will be a inlet for the gas, and there will be a valve system, sir.
All systems are of flap and non-flap types. So which disposable, which valve system is there, and not disposable or reusable, which valve system will be there?
I'm not sure, sir.
So in reusable, like Hassan trocar, there will be trumpet valve system, and in disposable there will be flap valve systems. So what is the reducer? What is this system and reducer?
The reducer is used when we have to use a smaller caliber instrument through a bigger trocar, sir.
Exactly. So that the gas cannot leak and you maintain that access with the smaller size instrument. What is housing part of a trocar? What is housing? So it is in
I don't know, sir.
Okay, it is in the cannula through which this valve, there is a valve and there is gas vent with the stopper.
Yes, sir.
These are the parts of trocar which we have shown. So one thing you must have come in when you were assisting or doing laparoscopic surgery, antegrade degestenting. So antegrade degestenting, how it is possible to do with any laparoscopic instrument?
Sir,
During
laparoscopy,
pyeloplasty, suppose you are assisting or doing lap pyeloplasty, then you will need, if you have sutured the posterior wall, now you have to put a degestant antegradely. How you can put degestant with the laparoscopic instruments?
sir, there are various ways. One is to, of course, we'll be using a guide wire, and that guide wire can be introduced through either a ureteric catheter, and that can be introduced through an outer sheath of the laparoscopic instrument, sir.
So this is the same thing. Outer tube with the vent for filling this you can introduce. Then there is inner tube which the instrument is itself attached under this handle. Different handles.
Yes,
so same thing is there. Can you identify this instrument? What is this instrument?
Hello.
Have you heard Maryland? Hello. Hello. This is Maryland.
Hello.
So have you heard? This was the Maryland which I was asking for. And these are endogastric forceps. What is this instrument which we commonly use in laparoscopy? Hello. I'm not audible. This is the scissors.
You are audible, sir. You are audible, but your voice is breaking. Probably the bandwidth is a little low.
So these are the scissors, which can be a straight tip or curved tip. Different types of scissors. What is this instrument shown? Hello.
So this is a suction cannula, sir. Which is
what are these two?
So this is basically, there are two channels, sir. One is basically for the irrigation, so there are two perpendicular line areas, sir. One is for irrigation and one is for the suction, sir. The below one is basically for the suction and the upper one is basically for the irrigation, sir.
Now, my advice to the students are that when your examiner is asking a specific question, do not lengthen your answer. So he is specifically asking the types of suction cannula. This is a trumpet type. For example, this is a trumpet type suction cannula. That is what he is asking for.
Okay.
So what is this instrument shown?
So this is a laparoscopic clip applicator, sir.
For which you can apply which clips?
Sir?
Liga. Through this you can apply which clips?
So we are applying the titanium clips, sir. This is the Liga clips, basically.
Can you identify this instrument?
So this is a bowel holding forceps.
Anybody?
So
Just
bowel hold,
see the
grasper.
tips.
Bowel grasper, sir. Bowel holding forceps.
Actually, this is crochet, which is very similar to bowel grasper. Bowel grasper has a straight to. This is not straight. See, this is curved.
Okay.
This guy is curved. The bowel grasper, this will be a straight, and there will be one central hole in the both the bowel grasper. But here, this is curved, and this is crochet, which we use for fine dissection, because just like in lap donor nephrectomy and all this, and during dissection of renal artery and vein during lap donor nephrectomy, you need crochet when you do fine dissection to remove the adventition and other structures from the vessel when you deskeletonize vessels. So this is important. This is actually we were also confusing with the bowel grasper, so that's why. This video is not running. This video was to show this thing crochet being used in abdominal nephrectomy. What is this structure? Hello.
So this is a hook, sir.
Hook is used for?
Dissection, sir. It is used for dissection along with cautery.
Like in lap nephrectomy or lap pyeloplasty, we use a hook in the initial stage when you.
So we are mobilizing the bowel initially, and that is done with the help of this hook, sir. Along with that, there are certain fine dissections which is also continued with the hook, sir.
This is same spatula which will work as an alternative. What is this?
There's a straight tip needle holder, sir.
So there are different types of needle holder which comprises tip, shaft, and handle. Handle can be pistol shaped or inline. So with your what are the features? Should be the features of needle holder. There are three important features which you should see in the needle holder. You should not let your needle slip. It should not be traumatizing to your suture, and handle should be easily movable. So what is this?
So these are the titanium clips, sir, of various sizes. This is the yellow one is the 400 and the green one is 300, sir.
What is this?
These are the hemlock clips, sir.
Hemlock clips uses.
So this is basically used for ligating the vessels while we are doing so any vascular structures which we basically ligate, sir.
What is the gold color coded for?
So the gold color is actually XL size.
Yes, a very large size. When we use in donor nephrectomy, sometimes the veins and last, then in that cases we use gold color. Have you come across this name rescue stitch?
No, sir.
Rescue stitch is a stitch which should be ready on your laparoscopic tray and table, because sometimes when there is bleeding, that's 4-inch tray, 4-inch suture you use, and one end you tie this hemlock so that You do not need to ligate to
Oh, yes.
write a not initial. Okay.
I didn't know the name, sir. We have used it.
So this one.
This is the Hemlock clip applicator, sir.
And this is the color code. Okay.
Yes, sir. Okay.
This you can rotate.
Yes.
And what should be the most important point when you apply Hemlock?
Circumferential dissection of the vessel, sir.
Both the ends of the clip should be visualized, and that is only after the proper dissection of the vascular structures.
One thing I would ask, what is gel port? Hello. What is gel port? What is gel port? Have you?
It's a special form of a port, sir, which can be used to have multiple ports through a single incision, sir.
In hand-assisted laparoscopy, we are also using it. So that is in short about laparoscopic instrumentology. Much time has been taken, so I don't have to go further. I think it is enough because as sir was saying, them unless sir you will not be given all the 1 or 2 instruments you will like to be asked to pick up and then ask about it. So that's okay. Thanks.
Yes, Ahsan sir, thank you. Thank you. This was the most concise presentation and with most pertinent points. So that concludes our this session for instruments in urology. So I thank all the teachers, the chairperson, the secretary of the Zone USI, and the students to participate in this program. So that concludes it. Dr. Ranjan De, sir, with your
Yes, sir.
permission, can
Thank
we?
you.
Can we conclude
Thank you,
this?
Demallo. Today, this is the penultimate weekend. I started with the same statement that this is the penultimate weekend, and it's an excellent job that has been done by all the moderators and the teachers till date. And the next week we have only BPH and the andrology, which will cover the entire subject on neurology, which we have covered over 2.5 months. And individually, I have to thank Dr. Demallo Gangobadhyay, the consultant urologist of Apollo Hospital, Calcutta, Dr. Bastav Ghosh, the consultant urologist, AMRI Hospital, Calcutta, Dr. Hirok, Dr. Anirban, Dr. Pramod, Dr. Rajkumar, and Ahsan. All of you have done fantastic job in the entire day, especially the radiological session was so informative, even for the practitioners, those who have logged in, got a lot of information, how to read the MRI especially, and the importance of different images are so lucidly explained today. I think it is of great help for the students to face their examination. With this, I thank once again our Sarkar and also the students, those who have actively participated. Today's our class session has crossed more than 4 hours, and they were all eagerly answered all the questions. I thank you all. I'll be extremely happy this comes to an help for your coming examination. Thank you. Hoping to meet you in the next weekend for the next session, and once again welcome you all. Thank you very much.
Thank you. Goodbye.
Demallo, we can close it.